years of service, and he was a professor and HOD at former professor and HOD at Mysore Medical College. Over to you, sir. Gurudas, sir. Thank you, sir.
Thank you, Rajesh. Can I share the screen?
Yes, sir, please.
Okay, can you see the slides?
Yeah.
Hello?
Yes, sir, it's visible. Perfect. It's visible and perfect, sir.
Okay. Thank you very much. Good evening to everybody, and it's a real pleasure again coming back after 1 week to this particular ISA PG update session. So I really appreciate the efforts being done by ISA Kerala people, and so much of effort being spent on teaching the PGs, and all the PGs all over India probably are benefited by this. So thanks ISA Kerala for this. And I would also like to thank Dr. Brijesh, Vijesh, Dr. Rajesh, and Dr. Nazar, and Dr. Venkatgiri, the President-elect, for this opportunity again. So I would also like to bring greetings from the hospital and the medical college, JSS Medical College and Hospital, where I am working. Now, last time when I did the lecture on anesthesia machine, I was telling you people that anesthesia machine, mainly the pneumatic component of the anesthesia machine and also the anesthesia workstation, is very important for the exam purpose. And a lot of questions will be asked for you regarding the pneumatic system. And this pneumatic system is usually classified as high pressure system, intermediate pressure system, and the low pressure system. So up to the pressure regulators, cylinders, and the yoke assembly and the pressure regulators, up to this is the low pressure, high pressure system. And from distal to the pressure regulators up to the flow control valves, we have the intermediate pressure system, and beyond the flow control valves up to the common gas outlet, we have the low pressure system or the circuit. Since I had already spoken about in detail about the high pressure system, today I'll be talking to you regarding all the parts and the importance of these parts, and what common questions will be asked for you in the exams regarding these systems, the intermediate system and the low pressure system of anesthesia workstation. So let us start with the intermediate pressure system. The components of intermediate pressure system, that the pipeline supply is one of the most important part of the intermediate pressure system, because the pipeline pressure is usually 55 to 60 psi, and the pipelines are attached to the intermediate pressure system. Since last time I had in detail discussed about the pipeline system, especially the disconnection, the ammeter index safety system connection, and non-interchangeable screw thread connections, and all those things I had already discussed. So today I'll not be discussing about the pipeline connections. So the other parts of the intermediate pressure system, you have the fail-safe valves. So in the high pressure system, in the older machines, we had the master-slave regulators, so that those have been replaced by fail-safe valves in the modern workstations. We also have an oxygen supply failure alarm in the intermediate pressure system, plus the second stage pressure regulator, which is there in GE machines, and it is not there in case of Draeger machines. And we also have oxygen flush valve. So let us know more about these individual parts and the questions that are asked on these individual parts. So let us start with the fail-safe valve. You can see here the fail-safe valve is just distal to the first pressure regulator and also distal to the pipeline system. It is mainly present on the nitrous oxide side, and it is proximal to the second stage pressure regulator in case of GE machines, and in Draeger machines we don't have the second stage pressure regulator, so it is downstream of the flow control valves. So this fail-safe valve you can just see here, because it has to have the oxygen is connected here. So for opening of oxide, the flow, the oxygen pressure has to be there. So only because of the oxygen pressure into this fail-safe valve, so nitrous oxide can flow out into the second stage pressure regulator or into the the flow control valves. So there are some differences in these fail-safe valves as far as GE machines and Draeger machines. So in the GE workstations, these fail-safe valves are called as the oxygen failure sensor shut-off valves, or in short, they're called as shut-off valves. And whereas in Draeger workstations, they're called as oxygen failure protection devices, or in short, OFPDs. There is definitely quite a bit of difference is there in the shut-off valves and the OFPD. Just sometimes you may be asked in the exam, what is the difference between these GE machines and Draeger machines regarding the fail-safe valves? So let us know about it. So this is, the shut-off valve. So in this shut-off valve, this is mainly present in the GE. You can see this fail-safe valve. So oxygen, flow has to be there. So you can see here, one chamber is there, the oxygen chamber is there, which is connecting to a diaphragm and a piston with a thrust pin is there. So this is connected to a valve seat. So whenever oxygen pressure is more than 25 psig, so this thrust pin will see that the valve seat is, is totally opening the valve, and then the nitrous oxide is easily flowing. So whenever the pressure falls to less than 25 psig, so then what will happen is, the thrust pin will come down and the valve seat will completely close the valve. That means it is going to completely shut off the flow of nitrous oxide in GE machines, especially when the oxygen pressure falls to less than 25 psig. And what actually flowing into the flow meters is only oxygen, and no nitrous oxide will be flowing. And this is what is called as shut-off valves. Whereas the difference in case of the Draeger machines is, what is called as the oxygen failure protection devices. So these are actually, they're almost totally different from the shut-off valves. They're actually like a proportionating devices. So let us see how the proportionating devices, especially because of the OFPD, will be working. So now in these Draeger machines, again, the oxygen has to flow into a chamber which is connecting to a piston is there, and this piston is connected to a nozzle. So once the piston is connected to the nozzle, as long as the pressure of the oxygen supply is more than 50 psi, so this nozzle is out of the path of nitrous oxide, and nitrous oxide will be flowing out into the system with the same 50 psig, that is a pipeline pressure. So now let us see what will happen once the pressure of oxygen starts decreasing. So once the pressure starts decreasing, and suppose if it is just, let us say that it has come down to 25 psig, so the nozzle starts coming down, and it partially occludes the, the path of nitrous oxide. So because of this, the outlet pressure of nitrous oxide also reduces proportionately. That means the oxygen pressure has come down to 25 psig, so nitrous oxide pressure also has come down to 25 psig as it is going towards the second stage pressure regulator, or it is going towards the flow meters. So once the pressure comes down, oxygen pressure comes down to less than 10 psi or less than 10 psig, so this nozzle completely comes down and totally occludes. So then there won't be any flow of nitrous oxide, and only the flow meters will be getting only the oxygen. So this is called as oxygen failure protection device, and this is slightly different. It is almost like a proportionating device when compared to the shut-off valves. Now I'll just show you a video, because though they are called as oxygen fail-safe valves, they are not actually fail-safe. They are actually, it's a misnomer, and they are actually replacing the master-slave regulators and almost function like master-slave regulator. So I'll just show you. Sometimes you may be asked about demonstrate whether the master-slave regulator is working or not if in the older machines, and the fail-safe valves also have the same mechanism. So now we can just go with the master-slave mechanism. Just look at this video and you will know how to know whether master-slave mechanism is there and whether the fail-safe system or really fail-safe or not.
There is no audio.
You're not able to hear?
No, sir.
Audio you're not able to hear?
No.
Okay. Then what I'll do is I'll talk. Okay.
Yes, sir.
Because I am hearing the audio.
Binil,
what
can
should I
you
do?
hear the audio? I cannot hear.
Okay. What about my voice?
Yeah, that's so very clear.
Okay. So
sir, you have to share your audio also along with the video.
Okay, how to do that?
It's there, sir, on the right hand, that the dots are there. There you have to click and you have to share the audio also.
Okay. Just I'll do that. Then this. So it is there actually, volume is full.
So while you are sharing the video, sir, along with video, you have to share the audio also.
Okay. Anyway, what I will do is I can describe only.
Okay, sir.
Okay. Now let me play this video. I think you are able to see this video. So what I'll be doing is, so I'll be demonstrating the master-slave mechanism here. So, many times you will be asked about this master-slave mechanism. So what I'll do is, I'll open up the oxygen I've opened. So because I've opened up the oxygen cylinder, so there is oxygen pressure is there. Because of the oxygen pressure, the slave regulator nitrous oxide I can definitely open up. So now I am opening nitrous oxide. Easily you can see the nitrous oxide also I can open up. What I'll do now is, I'm just going to close the oxygen cylinder. So once I close the oxygen cylinder and see that there is absolutely no oxygen that is flowing into the nitrous oxide regulator, so I'll just see that there is no oxygen flow or oxygen pressure. Now you can see the nitrous oxide is also falling. So that means since there is no oxygen flow into the valve that is in the pressure regulator of nitrous oxide, there is no flow of nitrous oxide. Now what I am doing is, I am again opened the oxygen cylinder. Now after opening the oxygen cylinder, now whether this fail-safe valve is really fail-safe or not, or the master-slave regulator is going to protect person by getting any hypoxic mixture, what I'll do is, now I'll try to open only nitrous oxide. So when I only open nitrous oxide, I can still give only nitrous oxide to the patient. Just watch the video. So I'll be just opening the nitrous oxide now. You can. So now you see I opened the nitrous oxide. So now I can give only nitrous oxide, and with the same thing about fail-safe valves also, I can still give only nitrous oxide. That is why what is required is proportionating devices are required at the flow control valve level. So that is very important. So that's what I'm going to discuss later about the proportionating devices. So now coming to the other part of the intermediate pressure system, this is called as the oxygen supply failure alarms. So the machine standards dictates that when oxygen supply pressure falls below a threshold, usually about 30 psig, the medium priority alarm shall blow within 5 seconds. So this is the standards are there. So in the older machines, what we had was the pneumatic alarms were there. So these pneumatic alarms, so they were actually called as the Bowman's whistle or the Ritchie whistle. So many of the older the anesthesiologists, I cannot say older anesthesiologists who have worked with the older machine have seen these kind of Ritchie whistle. So I have also gone through with these Ritchie whistles, especially when we had Mark III or even Boyle Basic, they had these Ritchie whistle. So when oxygen is connected to the machine, there used to be a pressurized canister. Usually it used to be placed horizontally within the intermediate pressure system. So that canister will fill with oxygen as soon as you open the cylinder or you connect the machine to the pipeline system. This canister will fill with oxygen. So whenever the pressure of oxygen from the main supply falls below a certain decreased pressure, so the oxygen will flow from the canister into the vessel and that vessel will blow. So that is what the pneumatic alarms. I'll just show how it would function. Here you can see this is the oxygen source that is coming and entering. This is what is the canister or cylinder I was talking to you about. So this cylinder will have the oxygen filled as soon as we open the cylinder or the pipeline connection. Now you can see there is a spring here. Because of the pressure of oxygen, you can see this spring. The spring is moving away and then it is stopping this oxygen from this canister, activating the vessel. So whenever the pressure drops, the spring will push the particular valve seat away from the canister, and so that there is direct connection between the canister and the vessel, and the vessel will start out. So this is what was the pneumatic type of oxygen, low pressure oxygen alarms. But what was the problem with these pneumatic alarms? They have been now replaced with electronic alarms. The problem with pneumatic alarms is, the standard anesthesia machine standards require that the alarm should keep going on till the pressure is restored, oxygen pressure is restored. Till then the pressure, the alarm should be there. So with these pneumatic alarms, as long as the oxygen is there inside this canister and activating the vessel, once the oxygen finishes in this canister, so the vessel also will stop, giving the whistling sound. So that is one problem with this pneumatic type of canisters. So the other problem is, what they thought was this small amount of oxygen, whichever is there, whenever there is oxygen supply is decreased, this oxygen should have been used for the patient in order to prevent hypoxia rather than activating the vessel. That is why with the modern workstations and also later versions of Boyle Basic and also Mark III, so it has been replaced by what is this called as the electronic alarm. In this, you can see this because why I'm showing you this, postgraduates, because you may be asked after showing this in the machine, you may be asked to name this. What is this? So this is an electronic alarm that has replaced the pneumatic alarms. And usually you have to keep the battery here and you have to check whether the battery is active or not. So that is one thing. So whereas with modern workstations, we have electronic alarms, pressure sensors are there, and these pressure sensors will continuously sensing the supply pressure of oxygen. So whenever in GE machines, whenever the oxygen pressure comes down to less than 28 or less, so it gets activated. And in Draeger machines, so once the pressure comes down to 30 or 37, again it gets activated. So this is what is called as the electronic alarms or low pressure alarms that are there incorporated. Again, a safety feature adopted in the intermediate system. So next, the part is the oxygen flush. You all have used this oxygen flush. It is can be seen here. It is with O2 plus. So the button is there. So the button is slightly inside. If you can see, that is also can be asked as a short note. Asked in the practicals, because by mistake also you should not be able to unnecessarily activate this. So that is one thing. That's why it is slightly inside. And the mechanism of the flush is very simple. The button is there. The button is connected to a spring, and the self-closing valve is there. So once you press this button, so the valve seat opens up, and the oxygen will start flowing out, and this oxygen flow will be flowing at a velocity of 35 to 70 liters per minute. So, and the pressure of this is the 55 to 60 psi of the pipeline pressure or the cylinder pressure of 45 psi. Now, because here you can see the flush valve, it is directly connected to the pipeline system and also to the pressure regulator here. So the advantage of this oxygen flush valve, sometimes you may be asked when you are going to use it. there are many indications for use of this flush valve. The main indication is, for example, now you're ventilating the patient with a mask. So when you're ventilating a patient with mask, especially the edentulous patients or patients with beard, there is a difficulty in mask ventilation. So there will be a lot of leak around the mask and then the face. So in such situations, you can definitely activate the flush valve so that you're giving the flows much higher than whatever the leak is there, and you can easily ventilate the patient. So that is one of the most important aspects of this oxygen flush valve. It is a safety feature. The other times when we use this oxygen flush valve is when we want to pressurize the whole system to check for the leaks. That I'm going to talk to you later. And the other thing is when you want to do a pathics test, then also you will be using this oxygen flush valve. So these are some of the indications for oxygen flush valve. But there are some problems also associated with oxygen flush valve. So one of the problems is, because it is bypassing the flow meters and also the vaporizers, because of that, it can dilute the anesthetic. So you have to be extremely careful, because by repeatedly activating it, you can produce lighter planes of anesthesia. And the other problem is because it is going at a pressure of 55 to 60 psi, so it can produce barotrauma to the patient as well. So in case of Draeger machines, this particular problem has been taken care of because by the use of the fresh gas flow decoupling valve. So this may be asked for you when you are asked about the oxygen flush system. So you may be asked what happens in Draeger machines. What is this fresh gas decoupling valve? So this I'm showing you. This is a closed circuit, and this is in the inspiratory phase. So during inspiratory phase, what will happen is the gases will go only from this piston ventilator. So this, what is I'm showing is the piston ventilator is there. From the ventilator, the gases are pushed to the patient during inspiration, and during inspiration, the fresh gas decoupling valve is in the closed position. It will not open up. So all the fresh gases are directly entering into the bag instead of going directly to the patient. So that way, even by accidentally, if flush valve is activated, the fresh gases will not directly go to the patient, and that's how the barotrauma is prevented. This fresh gas flow decoupling valve will open during expiration, so that the expired gases will pass through through the canister and enter into the reservoir bag. In the meantime, the piston ventilator is creating a negative pressure and taking the fresh gases also from the gases from the reservoir bag. That's how the fresh gas flow decoupling valve will function. So now coming to the another part of the intermediate system, these are the second stage pressure regulators. These second stage pressure regulators, I told you that they are present only in GE machines. They are not there in the Draeger machines. So these second stage pressure regulators are just upstream of the fail-safe valves and the downstream of the flow meter assembly. So what they do is, they are going to reduce the pressure. Oxygen pressure is reduced to 14 psig, and nitrous oxide pressure is reduced to about 26 to 29 psig. So there is a definite reason why, that you may be asked why there is a, difference in the reduction of pressure of the second stage pressure regulators of oxygen and nitrous oxide. Why oxygen is reduced to 14 psi and why nitrous oxide is slightly higher pressure it is reduced. So this is mainly, I'm going to talk to you about proportionating devices. So in order to maintain 3:1 ratio between the nitrous oxide and oxygen in case of link 25, this also will help. So let us see what are the advantages of the second stage pressure regulator. Now, one thing we should always remember that when too many OTs are there and many of the OTs are working and everywhere oxygen is being used, there can be some amount of fluctuation of the oxygen pressure. So from the pipeline directly coming to the flow meter, the fluctuation of pressure, if it occurs, the flow can alter, isn't it? So because flow entirely depends on the pressure, so naturally there can be some amount of alteration of the flows can be there. So the flows will not be very accurate. So suppose with these second stage pressure regulators, because the pressure is further reduced, oxygen pressure is reduced to 14 psi and nitrous oxide is reduced to 26 to 29 psig. So even though there is some amount of fluctuations, the flow into the flow meters will be very accurate. So that is one thing. And I told you that 3:1 ratio of nitrous oxide to oxygen in link 25 can also be maintained because of this particular, second stage pressure regulators. So in Draeger, I told you that in Draeger machines, many of the Draeger machines do not have the second stage pressure regulator. Then how the pressure is reduced in Draeger pressure regulators? They use, what is this? We all know about this flow restrictors, which uses the Bernoulli's principle. So we know that Bernoulli's principle is that when gas flow is flowing through a tube and it encounters a narrowing in the tube, at the place of narrowing, the potential energy decreases, kinetic energy increases. That means, the energy will not change, energy will only change from one form to the other. That means potential energy is the pressure decreases, the velocity will increase. So that is what is the Bernoulli's principle. So how this Bernoulli's principle is used in flow restrictors in Draeger, we'll just see. Now this is, the needle valve of the flow meters. You can see the piping which is just proximal to the needle valves or upstream of the needle valves. Now what is happening here is the tube is, there is some narrowing of the tube has been made here. So because of the narrowing of the tube, the gases which are coming through this narrowing will have an increased velocity and decreased pressure. So that's how, there is going to be some amount of decreased pressured gases will be entering into the flow meter in Draeger machines. So that also, even though there is some amount of decrease in the pressure, the flow will not alter much. But definitely there is some advantages and disadvantages are there with the flow restrictors. So what is the advantage? Advantage is that, we are not using a second stage pressure regulator. So definitely it is going to reduce the task. But the disadvantage is, any sudden fluctuation in pressure. For example, there is a decrease in pressure. So the flow across the flow restrictors will also decrease because the pressure has decreased. So that is going to definitely produce some amount of alterations in the flow in the flow meter. So there will be some amount of decreased accuracy of flow through the flow meters because of these flow restrictors. So second stage pressure regulators, the flow will be very, very accurate. Now, coming to the next part is that many times you'll be asked about how many connections are there in the intermediate system for the oxygen source, whether it can be from the cylinders or it can be from the pipeline system. So this is one common question that is asked by many of the examiners. So you have to say there are 6 connections, especially in GE machines there are 6 connections and Draeger machines there are 5 connections. Let us see what are these connections. Now, most important thing is oxygen directly will be flowing through the second stage regulator to the flow meters. This is one of the connections. The second connection is to the fail-safe valve of nitrous oxide. The third connection is to the low pressure alarms. So then you also have in many of the workstations, you have auxiliary flow meters, oxygen flow meters. That is the 4th connection. And 5th is to the oxygen flush valve. And 6th is to the bellows ventilator. That, in many of the GE machines, we have bellows ventilators. So in order to drive the gas, you require oxygen. Whereas in case of Draeger machines, you have a piston-driven, electrically driven ventilators. There, oxygen need not be connected to the ventilator. So that's why I told you in GE machines, you have 6 connections, and in Draeger machines, you have 5 connections of the oxygen supply source. Now, let us discuss about the low pressure circuit. The low pressure circuit mainly consists of the flow meter assembly, and you have a back bar which is connected with the vaporizers, and you have a check valve in case of GE machines, and then the common gas outlet. So let us discuss about each one of them. So the flow meter assembly in the older machines used to have only 2 flow meters. That means, or maybe one flow meter for each gas used to be there. And the problem in those single flow meter was, if I want to go for low flow anesthesia technique, then the accuracy of flow will not be there because only single flow meter for low flows and high flows. So that this thing has been taken care of in the newer machines. So this is a safety feature in the newer workstations, whereas we have 2 flow meters dedicated to each of the gas. So one flow meter which is mainly dedicated for low flows, so you can be very accurate for the low flows. The other flow meter is for the high flow. So this is one of the safety measures. Now coming to the flow control knobs. So many times this is also another question they'll be asking you. The flow control knobs are touch coded and they are color coded. So here you can see the oxygen is white and nitrous oxide is blue and air is black and white. And oxygen flow control knob is the largest when compared to nitrous oxide and air, and oxygen flow control knob is cylindrical when compared to these two, which are conical. And the flutes you can see here, the flutes of the oxygen are widely placed. And because with that only you can just touch it and you can know that you are touching oxygen. And whereas on nitrous oxide and air are narrowly placed. One more thing is again an exam question is the oxygen flow control knob will be slightly more forward when compared to nitrous oxide and air. So it is coming out more. If you want to reach any of the knobs, you can reach oxygen knob more easily because it is protruded more. So this is another question they'll ask you, why oxygen control knob has made to protrude a little more than the nitrous oxide and air flow control knobs. So now is the proportionating devices. When I was talking to you about fail-safe valves, I was telling you that the fail-safe valves are no more really fail-safe. It's a misnomer. So because of that, we require to have proportionating devices. So these proportionating devices are again different in GE machines and in Draeger machines. In GE machines, these proportionating devices are called as Link 25, and in Draeger machines, they are called as oxygen ratio monitor control or sensitive ratio controller. Both these oxygen ratio monitor control and the sensitive ratio oxygen ratio controller, the principle is same, but they do differ. Link 25 is more of mechanical, whereas the ORMC or SORC is more of or almost purely the pneumatic. So let us know how they differ. Now you can see this is the Link 25. So I told you that in the Link 25 is more mechanical, and you can see the chain, and the chain is connecting the sprockets. There are sprockets for oxygen and sprockets for nitrous oxide are also there, and this the Link 25 you can see here. This is in between the flow control knob and the needle valves. So it is in between that. And we do have, as I told you, that the sprockets are there for both oxygen and the nitrous oxide. So these sprockets for oxygen, it is 29 the teeth are there for oxygen sprocket, and 15 teeth are there for nitrous oxide sprocket. So if you want to rotate, when you rotate 2 turns of nitrous oxide, you can rotate 1 rotation of the oxygen. That means this itself will produce a 2:1 ratio. But I was talking to you about 3:1 ratio because these proportionating devices will see that minimum amount of oxygen you can always give to the patient is 25% of the total flows. So that 25% of oxygen has to be maintained. So for that, if as long as you have a 3:1 ratio between nitrous oxide and oxygen, you can always have a minimum amount of 25% of the total flows. So that again, it requires some amount of pneumatic assistance also. That's why I told you that there is a difference in the pressures of the flows for oxygen flow meter and nitrous oxide flow meter. Here again, it is 26 for nitrous oxide and 14 for oxygen. So because of this also, the ratio becomes 3:1. One more thing, if you just see the needle valves of nitrous oxide and oxygen, there is slight difference in the shape of these needle valves of nitrous oxide and oxygen. So the needle valve of nitrous oxide is slightly blunt, and so because of that, there can be more flow of nitrous oxide through the needle valve when compared to oxygen. So with this also will help in maintaining the 3:1 ratio of oxygen, nitrous oxide to oxygen. So I just wanted to show you again this ORMC again. I just want to describe you about the ORMC, that is, or SORC. That is in case of the Draeger. I told you that in Draeger, it is more of pneumatic rather than mechanical when compared to Link 25. So how this SRMC or ORMC will work? Now you can see here, the oxygen is flowing into the flow meter of oxygen, and nitrous oxide, there is a flow meter here. There are resistors in oxygen flow meter and nitrous oxide flow meter. You can also see here the nitrous oxide flow meter resistor is, the amount of resistance it is going to offer is much less when compared to the resistor that is there in the oxygen flow meter. Oxygen flow meter resistor, will have slightly higher resistance when compared to nitrous oxide flow resistors. Now, once we open oxygen flow into the flow meter, because of the resistor, there is a backflow of oxygen into another chamber, which is, we can say that it's the oxygen chamber. So the back pressure, because the backflow is going to push this diaphragm inside the oxygen chamber. This diaphragm is connected to a shaft, and this shaft is entering into a nitrous oxide chamber, again containing another diaphragm. So because of the oxygen flow and the back pressure, so this shaft is shifted or pushed towards the left side, where we have a nitrous oxide slave control valve. So once the shaft is pushed towards the nitrous oxide slave control valve will open, and once it opens up, nitrous oxide can flow into the flow meter of nitrous oxide. Suppose if there is no oxygen, you are not opening the oxygen, then you cannot open nitrous oxide also. So this is one of the things with the ORMC. Suppose you have opened oxygen, but you want to open more of nitrous oxide. So if you are trying to push more nitrous oxide through the flow meter, because of this resistance, again the nitrous oxide again will flow back, and it's going to push this shaft towards the oxygen side, and it is going to close the nitrous oxide slave control valve. And by closing that, or partially closing it, it is going to decrease the amount of nitrous oxide flow, so that it will always maintain, whenever you are using both oxygen and nitrous oxide, so that 3:1 ratio is always maintained. So this is a proportionating device that is there with the Draeger system. This is a purely pneumatic. Now here in this picture diagram, you can see, so the oxygen, we have stopped oxygen flow. So because we have stopped oxygen flow, so the nitrous oxide slave control valve is completely closed, because the shaft has moved towards the oxygen side, so no more nitrous oxide can flow. So here in this video, I'll be demonstrating how you can differentiate between, whether the particular system has got the Link 25 or whether the system has got the proportionating device like ORMC or SRMC. So this is very important for your exam purpose, because you may have in the exam center have a Draeger machine or the GE machine. Because I told you, in the GE machine you have the Link 25, and in the Draeger machine we have the ORMC or SORC. How to know whether which one is there? So just I'll open the video. So anyway, because you are not able to hear the audio, I'm going to talk about this. So it's mainly to differentiate between the Link 25 and SRMC. So in Link 25, so if you try to open nitrous oxide, automatically the oxygen also will start moving. You can see the oxygen flow control knob is also moving as you open nitrous oxide, because the link gets established once the amount of oxygen flow is less than or 25% or less than the total flows. So that is very, very important. And if I want to open only oxygen, I can only open oxygen, because then the link will not be established. So the link will be established between oxygen and nitrous oxide only when the total, when compared to the total flow, oxygen flow is or oxygen percentage is 25% or less. Then only the link gets established. That's why it is also called as link 25. So here what I have done is I have increased nitrous oxide. When I am increasing nitrous oxide, oxygen is also increased. When I stop the nitrous oxide and completely, the oxygen will remain like that. So it will not come down. So this is what is actually the link 25. Now let us see how the Draeger, the ORMC works. Now in this video, you can just see this is the ORMC or SORC of Draeger Fabius Plus. So I'll try to open nitrous oxide. So if I try to open nitrous oxide, unless I open oxygen, then only the nitrous oxide slave control valve will open and the nitrous oxide can open. Suppose I am not opened oxygen, then even any rotation of nitrous oxide, I will not be able to open nitrous oxide. This is in contrast with the link 25. In link 25, what happens if I try to open nitrous oxide, automatically the oxygen also will open. Here I am trying to open nitrous oxide, no flows are occurring. Whereas with link 25, if I am trying to open nitrous oxide, the oxygen also would have flown. So this is one thing, very important thing. Next, I'll try to open oxygen. I'll keep oxygen to about 1 liter, and then I'll try to open nitrous oxide. You just watch there. So I've just kept the oxygen to about 1 liter. Now I should not be able to give nitrous oxide for more than 3 liters because totally it will be 4 liters. So when you have 4 liters, oxygen will be 25% of the total flows. So what will happen here is you just see when I open nitrous oxide, the nitrous oxide will flow up to 3 liters, and after 3 liters, even though I am trying to rotate the nitrous oxide flow control knob, nothing will flow. Nitrous oxide will not flow further. So this is what is the proportionating device of ORMC or SROC. So in the exam, you can easily make out, just try to open nitrous oxide. If oxygen also start flowing, it is link 25. If you are trying to open nitrous oxide, nothing is flowing, then it is actually the ORMC or SROC. So that after that proportionating devices, now we will start knowing more about these flow meters, because we just completed the flow control knob and then the proportionating devices. Next will be the flow meters. These flow meters are called as TURP tubes, and they are made of very hard glass, which is called as the plexiglass. And here inside you can see the bobbin. So when the bobbin rotates, because of the movement, it is going to create electricity there. And if the electricity remains there, or that what we call it as a static one, so if there is a static electricity occurs, this bobbin will start sticking to the inner wall of the flow meter. So that is the reason a special chemical has been sprayed into the flow meter, and this chemical is called as a Croxtine. So this Croxtine will prevent the static electricity that is produced as a result of bobbin. So there won't be any sticking of the bobbin. So this is one thing you should know for the exam purpose. Sometimes you may be asked about. The another thing is, these flow meters are calibrated for each gas separately at sea level. So this is very important because the flow entirely depends on the viscosity and the density. The lower flows, viscosity governs, and in the higher flows, the density governs. And the density and viscosity will change with the particular gas. So that is the reason. So you have to have calibration for each of the gas. So that is why one common question you will be asked, suppose if there is a break, so let us say that the oxygen flow tube has broken. Can I replace with another machine's nitrous oxide tube? No, then you'll have to say you cannot, because each gas has been calibrated individually. So that you should always be able to tell about. So another thing is you can see a stop here at the bottom and also a top at the top. So the stop at the top is very important because it will prevent the bobbin disappearing into the back bar. This is again one of the safety features adopted in the flow meters. So one more thing I just want to tell you, because the oxygen may be flowing in the Draeger machine and also in the GE machines at slightly higher pressures. So how the pressure further drops, and in the common gas outlet, the amount of pressure will be just above the atmospheric pressure. It may be just between 4 to 8 psig. So how this occurs? Here the gases are flowing through a narrow space in the flow control valve. These are called as the needle valves. So here again, because of the Bernoulli's principle, the pressure drops, the flow increases. They are passing through a narrow opening here in the bobbin stop, and again they have to flow just by the side of the bobbin. Again, the annular space here will be narrow. So again, the pressure drop keeps on occurring, and as they flow through again the bobbin stop at the top, again the pressure drops. So there is a continuous drop in the pressure, and finally the pressure will be just above the atmospheric pressure at the common gas outlet. Another important thing you have to know for exam purpose is, these flow meters are tapered. You can see tapering. So the narrowest portion is in the lower part of the flow meter, and as you go up in the flow meter, it starts widening. So they'll ask you why the tapering has to be done. So this is another very important thing to know about, because the lower portion we require for more accurate flows. So whereas as you go up, you don't require so much accurate flows because for the higher flows. So because of this, when you have the tapering, so that you can have a longer distance for the lower flows, whereas you can decrease the distance between each of the readings for the higher flows. So overall, what happens is, because of this tapering mechanism of the flow meter, you can reduce the length of the flow meter. So this is what the examiner will expect you. So they'll ask you why the tapering has to be there. You have to say that in order to reduce the length of the flow meter. So sometimes they may ask you about the principle behind this flow meter and the bobbin, how it floats. So there is a space between the top of the bobbin and the inner wall of the flow meter, and this space is called as annular space. You can see the annular space here and here. So this is for the higher flows, and the lower diagram is for the lower flows. The annular space is much smaller for the lower flows, and it keeps on widening because of the tapering of and widening of the flow meter as we go up. So the annular space keeps on increasing. So there are two forces here. One force is because of the gravity force because of the weight of the bobbin, and the another force is because of the gas flow. So at any point of the the flow, once the force of gravity of the bobbin and the force of the gas flow equilibrates, at that particular level, the bobbin will start floating. And that is the basic principle behind this, why it stops at a particular level and starts rotating. And the second thing they may ask you is why the bobbin rotates. So this is again because, in the bobbin, at the top of the bobbin, you have the slanted flutes. Now, when the gas flows, the gas is going to hit these flutes, and once it hits these slanted flutes, it makes the bobbin rotating. So that is what is very important. And another thing is, many times when you're using the flow meters in darker areas, especially in case of the radiology suits and all, you can see a dot here, fluorescent dot, and this dot also will be asked for you in the exam, why there is a fluorescent dot here, so that you can know that the bobbin is rotating, even in darker areas. And another safety features in the flow meter assembly is the backing of the flow meter assembly. Also, there is a fluorescent backing is there, so that you can see the bobbins rotating. There is another safety feature that is adopted in the flow meters. Nowadays, with modern workstations, you have the light is there. You can just put on the light and you can definitely see the bobbins rotating and the flows of the gas occurring in modern workstations. So in modern workstations, many times, especially high-ended workstations, you don't have these flow meters at all for individual gases. There can be, this Fabius, one of the Draeger machines. So here you can see the flow control knobs are there, and the digital display of the individual gas flows are there. And single flow meter is there, and it will be showing the total flows. And you can see here oxygen 2 liters. So the air is 1 liter and nitrous oxide is 1 liter. Total flows will be 4 liters. So there will be a digital display of the flows in some of the workstations. And in primers, Draeger primers, you can see here there are virtual flow meters. You can see the virtual flow meters here. So in this primers, what you have to do is you have to select the percentage of oxygen, FiO2, what you want to give, and you just select what is the other gas you want to use, whether nitrous oxide or air, and you also select the total flows. So based on that, it will be giving the flows, and you have the virtual flow meters. You don't have the the actual flow meters may not be there in primers and in many of the high-ended workstations. So again, I was talking to about the annular space. So if you combine the annular space on either side, what you get is an equivalent channel. So this amount of area is there for the gas to flow. So why this is important is, again, you can see here, for the lower flows, the annular space, the total space, the equivalent space is much, the breadth wise, it is much less when compared to the length. So because the length is higher than the breadth, so the flow is tubular or laminar flow that will be occurring here. Whereas as we go up, because the widening of the tube, so the annular space is much larger, or equivalent space is much larger. The width is much higher than the length. So because the width is much larger than the length, you call this as an orifice, and the flow will be orificial flow, or otherwise called as a turbulent flow. So we know that in case of low flows, because I told you the flow is laminar and it obeys the Hagen-Poiseuille's law. And Hagen-Poiseuille's law is flow is inversely proportional to the viscosity, and higher flows definitely, as we were speaking about, because the flow is orificial and turbulent, so it obeys the Graham's law of turbulent flow, and Graham's law says that the flow is inversely proportional to square root of density. So this is again a common question for you in the exam, because for higher flows it is always the density, and lower flows it is always the viscosity which governs the flow. And already I told you when we were talking about the calibration of these flow meters, they are calibrated at sea level. Suppose I take the same machine which has been calibrated, the flow meters have been calibrated at sea level to a high altitude area. For example, I want to use the same machine in Ladakh. So what will happen there? You know that the density decreases. The viscosity doesn't change with high altitude area. It is only the density which decreases. So the low flows, they are still accurate, but high flows can be totally inaccurate. Because what will happen is, because of the decrease in density, whatever you are thinking of giving the flow may be much higher. So suppose if the flow of oxygen is totally both are inaccurate, oxygen and nitrous oxide. Suppose nitrous oxide is flowing more than oxygen, then you will be giving an hypoxic mixture. So that is why the flow meters have to be calibrated at that level of altitude where you are going to use. So one more question that can be asked for you is regarding the sequencing of these flow meters. So nowadays we always have the oxygen. The most downstream flow meter will be the oxygen. So in the older machines, because many times in the exam the older machine is also kept and the new workstation is also kept, they may ask you this question. So in the older machine, oxygen may be upstream of all the other gases. So what happens is, if the oxygen is upstream of all other gases, suppose if there is a break in the flow meter of air which is in between oxygen and nitrous oxide, so when you start both oxygen and nitrous oxide, and oxygen may flow through that break and it starts leaking out. So what the patient may be getting is more of nitrous oxide and less of oxygen, and the patient may have hypoxic mixture being delivered. So in order to prevent that, now we have in modern workstations, we have oxygen will be the downstream of the oxygen flow meter will be the downstream for all other gases like nitrous oxide and air. So even if there is a break in the nitrous oxide flow meter, the nitrous oxide will be flowing out, oxygen will be going to the patient. Patient may have slight lighter planes of anesthesia, but he'll not will not be getting any hypoxic mixture. So this is also a common exam question that can be asked for you. But one thing again here, if the oxygen flow meter itself is broken, then definitely hypoxic mixture can be delivered to the patient. Coming to the back bar, so I'm showing you the picture of an older machine. So where the back bar has got the Boyle's bottles. So you have ether and trilene bottle. So why I'm showing you this? Sometimes you may be asked about this trilene lock, the exam. So what is this trilene lock? So trilene reacts with soda lime to produce phosgene, which can be toxic to the nerves, and many times it can even produce trigeminal neuralgia. So that means when you want to use trilene, you should not be using the closed circuit. That is what this trilene lock will produce. So when I'm using trilene with this trilene lock, so I'll not be able to switch over from open circuit to the closed circuit. Or if I'm already using the closed circuit, then I'll not be able to open this trilene. So this is what is called as a trilene lock. Sometimes you may be asked in the exam about this trilene lock. Suppose if that particular machine has got both ether and trilene as the vaporizers. So one more safety features adopted in the modern workstations is that in the older machines you could open 2 or 3 vaporizers simultaneously, whereas in the modern workstations you cannot open simultaneously 2 vaporizers. Because of the you can select only one vaporizer. In tech vaporizers, what you have is a selector tech. So one more safety features is that filling of these vaporizers. You have keyed indexed safety system. This also can be asked, what is the safety feature adopted in filling the modern vaporizers? So you cannot with these you can fill the vaporizer of a particular vaporizer with the same particular agent. You cannot fill a wrong agent into the vaporizer of a different agent. So this is what is called as keyed index safety system. This is also one of the safety features adopted in modern workstations. So one thing you should always know about is that in some of the older machines, you can see a check valve and a pop-off valve. Many of the students, when we ask about what is this, they may not be able to answer. So you just see here, this is what is a check valve and a pop-off valve. So in modern workstations also, in GA machines, we do have check valve. In Brager machines, we don't have the check valve. And the pop-off valve, or otherwise in the modern workstations, they are called as the high pressure relief valve. The high pressure relief valve is present in both GE and in Brager machines. Now, what is the importance about this check valve and pop-off valve? Sometimes you may be asked. So the check valve will prevent the back pressure. So, the pumping effect and pressurizing effect and all those things. So that is prevented because of the presence of this check valve. And, this pop-off valve, they may ask you what pressure the pop-off valve will open, because if there is an obstruction to the forward flow of oxygen from the common gas outlet, there can be a very high back pressure. So usually at 300 centimeters of water pressure, this check valve will open. So one more video actually I had made for you to see this how this the pop-off valve will work, because there will be a hissing noise once I occlude the pop-off valve, because you are not have not activated the sound, so I'll not use this particular video for you. So another thing, very important thing is, all these safety features will be there only up to the flow control valves. So we hardly have any safety features after or distal to the flow control valves. Now from the from the flow meter assembly to the common gas outlet, we do not have any sort of safety features. Because we don't have any safety features, there can be leaks in between, so that can produce a hypoxic mixture to be delivered. So it is very important to check for the leaks. So you can have a high pressure a positive pressure leak test. So what you can do is you can close the YPs, and then you can activate the flush. I was telling you that one of the uses of the flush is to check for the positive pressure leak test. So you maintain a pressure of around plus 20 centimeters or 30 centimeters, and this pressure should sustain for about 10 seconds. Then you know that there is no leak. But you have to do with the vaporizer opened also. So now we can see if the leak is there. Most commonly, the leak can be there at the vaporizer level. If there is a leak, there won't be any. You cannot have the sustaining of this pressure. But one thing about this positive pressure leak test is you cannot do this test when you have a checked valve. Suppose if you have a check valve, when you are doing a positive pressure leak test, it is going to check only up to the check valve. So you cannot check the most common areas where the leak can occur. So that is the reason why you should go for a negative pressure leak test. So with the negative pressure leak test, definitely it is called as a universal leak test. You can check for both the type of workstations whether you have a check valve is there or not. Like you see here, the check valve is there. I'm using a negative pressure leak test. Suppose there is a leak at the vaporizer level, so this bulb will keep inflated. It will not keep deflated, because it has to keep deflated for at least 10 seconds. Like you can see here, it has been deflated as you keep on applying pressure there. So, and you squeeze all the air, and the bulb has to keep deflated for at least 10 seconds. Then only that you know that there are no leaks. And if there is a leak, then it immediately inflates. So that's how you do a negative pressure leak test. This is one of the universal leak tests you can do. So with the modern workstations, you have automated self-checkout. So definitely you have to do, as before you start your case, you have to do a self-checkout test. So that is an advantage with the modern workstations. So you can check for the ventilator leak test, is there system leak test, compliance of the tubings, and safety relief valve test. All these tests have to be passed before you have to start the case. And whatever it may be, now what is the most important thing is still there is a possibility that the hypoxic mixture can be delivered. What is most important thing is an oxygen sensor, which continuously will be telling what is the FiO2 the patient is getting. So the oxygen sensor in the inspiratory limb, or ideally it should be there in between the patient's endotracheal tube and the circuit. Then only we know definitely that the patient is not getting any hypoxic mixture. So just to conclude, over the years the conventional anesthesia machine has definitely evolved into a very advanced case station, and a lot of things have been added in order to make it very safe. But the new solutions to old problems might rise new problems. So that is the reason you have to be very vigilant. A vigilant anesthesiologist, and just now I told you about the oxygen analyzer, are the most important things to prevent hypoxic mixture delivered to the patient, and you can be very safe to the patient. So thank you. Thank you, Rajesh.
Thank you, sir, for the excellent presentation. So can we go for the questions in the chat box?
Yeah, sure.
Yeah, so that's first question is, please explain the negative pressure leak test, how to do it.
So just now I told you require a sphygmomanometer bulb, and many times you will be supplied with this bulb when you are given when you buy the workstation. So to the common gas outlet, you fix this bulb and start you squeezing. You don't open up any gas in the flow meters. Start squeezing. So when you start squeezing, it is going to squeeze out all the whatever the air or gas that is present inside the system. So that so now it becomes totally deflated, and the bulb should remain deflated for at least 10 seconds to know that absolutely there is no leak. So that's how you do the leak test, negative pressure leak test.
Thank you, sir. There are many postgraduates attending this session because they have exams, practical exams next week.
Okay,
so that may be the reason for that repeated query. And another query is can you please explain once again the tapering in the flow meter? That also was explained once.
Yeah, already I had explained why tapering is required. Also, I have explained, and you have to say to, reduce the height of the flow meters. You have to have the, tapering, because if you don't have the tapering, then the length of the flow meters will be very long. So you must have seen, with low flow the first when you have the flow meter in series, the first flow meter, the whole length is only 1 liter. Suppose if you have the same type of 1 liter to that amount of length, you can imagine for 12 liters what will be the length of the flow meter. So that is why it has been, the tapering has been done. So for higher flows, the in between the different flows, the length is much smaller.
Thank you. So that's another question: is pressure relief valve and APL valve difference?
So pressure relief valve is in the, it is in the workstation itself. So whereas APL valve is in the circuit, that is the difference.
So can we examine can we say in the exam conventional machine is same as Boyle's machine?
Yeah, you can definitely.
And another question is from Dr. Vishnu Raj: these master and slave mechanisms and auto failure shut mechanism the same?
The master slave and almost the principle is same. But in master slave, you have in the primary pressure regulators, this mechanism is there. Like, the primary nitrous oxide regulator will be acting as a slave regulator to the oxygen pressure. Whereas the fail-safe system is slightly different. A separate valve is there. A fail-safe valve is there other than the primary regulator. So that is the difference. But principle is same.
Okay, so there is another question: what happens to vaporizer change in high altitude?
So vaporizer flow will not alter much the outlet flow, because as when you take these vaporizers, because vaporizers entirely depends on the atmospheric pressure. So when the pressure is reduced, the outlet flow will increase. The concentration remains same thing. So the concentration will not change with even when you take this vaporizers, especially the modern vaporizers to the high altitude area. The outlet concentration will remain same, and the pressure will increase. Actually, the outlet pressure will increase to meet the back value of the patient.
Thank you once again, sir, for the excellent presentation. I think that completes our questions in the chat box.
Thank you, Rajesh.
Postgraduates still can post your questions in the chat box. Sir will be there and he'll be happy to answer after the next session. Is it okay, sir?
Yeah, sure.
There is an announcement from the Dr. Binil. Dr. Binil?
Yeah, thank you. I'm just sharing the screen. Yeah. Tomorrow there will be a cultural fest, Amaze 2021, under the aegis of ISA Kerala State Chapter, organized by ISA Thrissur City Branch. So it will be at 7 p.m. I request all the members to join and enjoy the cultural festival tomorrow. And our next week's program will be at 6 p.m. as usual on Saturday. The first topic will be supraglottic airway device by Dr. Rakesh Kumar. He was formerly was working in Maulana Azad Medical College as professor in anesthesia, and at present he is associated with Geethanjali Hospital, and he is very famous for airway devices. So we are expecting a very good speech from Dr. Rakesh Kumar. And our second topic will be statistics part 3 from Dr. Rakesh Gar, who is working in All India Institute of Medical Sciences, Delhi, and Dr. Sudhish Kannan, who is a professor in anesthesia in Government Medical College, Bangalore. So this is the third part and the last part of statistics, which will be asked in the theory questions in PG examinations. And the third topic is a case discussion, PH by Dr. Praveen KP, from PG resident from Luth Hospital, Ernakulam. And the examiners will be Dr. Balabhaskar, past national president and professor in anesthesia in WIMS, Bellary. and the internal examiner will be Dr. Kamudi VM, senior consultant from Luth Hospital, Ernakulam. So I request all our PG students to join these sessions and enjoy our cultural festival. Over to Rajesh, sir.
Thank you, Dr. Binil. Next, we will go to the case discussion. It's a TURP, a case presentation by Dr. Smera Manoj. She is the postgraduate student in Baby Memorial Hospital, Calicut. And as we all know, TURP is one of the case scenarios a postgraduate is likely to get in their final exit exam. And for that, we are fortunate to have two senior-most faculties. Dr. Ramdas sir is HOD in Baby Memorial Hospital, and is my HOD in BMH Calicut. And Dr. Vinodan K is HOD in Medical Trust Hospital, Ernakulam. Over to Ramdas sir and Dr. Smera Manoj, and we have Dr. Vinodan K as external examiner. Okay. Dr. Smera?
Hello.
Yeah, Ramdas sir?
Wait, I'll start off. Smera.
Yeah, sure, please.
Smera, you can go ahead with the case presentation. Make it brief and crisp. Go ahead with the case presentation.
Okay. So is my screen visible?
Yes. You are visible.
Okay. So I'll be presenting the case of a 76-year-old male patient hailing from Calicut, who is a businessman by occupation, who presented to our hospital with complaints of increased frequency of micturition since 3 years, dribbling of micturition since 2.5 years, and difficulty in initiation of micturition since 2 years. In history of presenting illness, the patient was apparently normal 3 years back when he noticed an increase in his frequency of micturition. He had to wake up in the middle of the night in order to micturate. There is an increase in the frequency of micturition at night, which was initially once every night, and currently he has to wake up about 4 to 5 times at night. He also complains of inability to control his urine and associated with dribbling. He gives a history of increased difficulty in urination, in initiation of micturition, associated with decreased flow of urine in the past 2 years. There is no history of pain while urinating or blood in urine. There's no history of significant weight loss or loss of appetite. No history of recurrent fever, abdominal pain, or vomiting. He is physically active. He walks up to half an hour per day and is self-dependent for all daily activities. He can climb more than 2 flights of stairs without breathing difficulty. In past history, he's a known hypertensive since the past 10 years. He is on treatment for the same. He has been compliant with his medication and is on regular follow-up. He also gives a history of hyperlipidemia for the past 8 years, for which he is on oral medication. There is no history of chest pain, palpitations, flushing, or anxiety. No history of snoring. No history of breathlessness, swelling of feet, cough. No history of diabetes, bronchial asthma, tuberculosis, or epilepsy. In drug history, the patient gave us a history of tablet enalapril 25 mg BD, tablet atorvastatin 10 mg OD, and tablet aspirin 75 mg OD. He had no past surgical history or exposure to anesthetic drugs. He had no significant family history. In personal history, he's a non-vegetarian. His sleep is disturbed because of the nighttime awakening. Bowel habits are normal. He's a non-smoker and non-alcoholic. Hello?
Yes, you are audible.
Okay.
Yeah, continue.
So he's going to general physical examination. The patient is sitting comfortably on a chair. He is conscious, well-oriented to time, place, and person. He is moderately built and nourished with a height of 160 centimeter, weight of 60 kg, and BMI of 23.4 kilogram per meter square. Pulse rate is 72 per minute, regular rate, normal rhythm, volume, character, no radioradial or radiofemoral delay, equal on both sides, and all peripheral pulses are felt. No vessel wall thickening is felt. My patient is catheterized. Blood pressure was 150/90 millimeter mercury, right arm sitting position. Respiratory rate of 14 per minute, regular abdominal thoracic, no pallor icterus cyanosis, clubbing, lymphadenopathy or pedal edema. JVP was not raised. patient is afebrile. The patient does not have any hearing aids, and spine examination, there is not normal alignment, curvature, spinous processes are palpable, and the interspinous spaces are normal. Going to airway examination, his interincisor gap was 3.5 centimeters, sternal-mental distance of 17 centimeters, thyromental of 9 centimeters. TMJ had no ankylosis, Mallampati grade was 1, no dentures or missing tooth present. Neck movement was normal in all directions. There was no prognathism or retronasia. Systemic examination.
Give us a positive point, positive findings in your.
Yes, sir. There was no significant positive findings in cardiovascular, respiratory, or GI examination or the examination.
So tell us briefly about the case. What exactly?
Yes, sir. So this patient is a 76-year-old man presenting with complaints of increased frequency of micturition, urgency, dribbling, along with frequency and difficulty in initiation of micturition since the past 2 to 3 years.
Hello? Yes?
Hello. He's a known hypertensive since 10 years on regular ACE inhibitors, and history of dyslipidemia since 8 years on tablet atorvastatin. His meds was more than 4. Airway and systemic examinations were within normal limits, and he has currently been posted for transurethral resection of prostate.
Okay, we know then.
Hello, Dr. Smera. Yeah, hello. Hello, Dr. Smera. I think
yes,
it is Smera. Yes, okay.
Yes, sir.
Yeah, it's nicely presented, but I would like to know what exactly will be the major points you want to highlight in this, in the history and the findings.
Yes, sir. The points that I would like to, in favor of my diagnosis of benign prostatic hypertension, benign prostatic hypertrophy, this patient has increased frequency of micturition along with urgency and incontinence along with nocturia and poor stream of urine. And in regards to his comorbidity, sir, this patient is a hypertensive who is on regular treatment and he is compliant to his medication, and looking for a systemic examination, I did not find any history suggestive of any end organ damage due to hypertension in this patient. This patient was also well oriented to time, place, and person, and his mentation was fine, sir, and he was doing all his activities of daily living on his own. Then, sir, even his systemic examination did not reveal anything specific, sir, significant.
Because we are dealing with a patient who can go into hypervolemia, would you ask anything special in this patient, in the history?
So, because the patient can have, we will have to ask history of intake of diuretics, sir.
Okay.
The patient is on diuretics, and that in case it will increase our degree of hypovolemia.
No,
then,
I'm talking about hypervolemia, not hypo.
Hypervolemia, sir. So we'll have to ask history of congestive heart, cardiac CAD, history of coronary artery disease in this patient, because if the patient does have hypervolemia, the chances of its effect on the myocardium is very high, sir. So we'll have to ask history pertaining to if the patient has history of dyspnea, or the patient has chest pain or palpitation, or if the patient has orthopnea upon lying down, or cough, or paroxysmal nocturnal dyspnea.
Anything else you will ask in the history, thinking of the possibility of hemorrhage, excessive hemorrhage?
Sir, we would like to know if the patient is anemic. So we would have to ask history if the patient has any history of undue palpitations. That is, if the patient is feeling his heart rate, and if the patient has history of needle edema, if the patient is in congestive heart failure because of anemia. Hello, sir.
Yeah.
If the patient feels fatigue, we'll have to ask if the patient is weak, he feels fatigued, if he feels tired.
What about recent urinary tract infections? Do you think that is an important history to us?
Yes, sir, recent history of urinary tract infection.
Okay.
Why is it important?
Yes, sir, recent UTI, if the patient has, again, that could lead to hyperemia in the area itself, leading to more hemorrhage. And also the patient as such can go into post-operative sepsis. Urosepsis can occur, hence we would have to ask for recent UTI.
Yeah, they could also have high amount of hemorrhage because of the infection. Yes.
Yes.
Okay. Another history I think you should ask is the frequent, how many times he has been catheterized, and each catheterization increases the hemorrhage. So that's been shown in the surgical. Okay. What about the drug history?
The drug history in my patient, he is on AC inhibitors, as well as he is on aspirin, 75 mg, and he is on statin.
Okay.
What are the anesthetic challenges this patient?
Sir, in this patient, since because of his age, sir, he's 76-year-old. So along with that, his comorbidity is hypertension. So our anesthetic challenge would be the comorbidity itself, that is hypertension itself, can have this effect on different end organs of the body, the heart as well as the brain and the kidney. So we would have to maintain the perfusion to all these organs intraoperatively. Then because the patient is, he's a geriatric patient, we would have to assess his cognitive function preoperatively because there is high chances of postoperative cognitive dysfunction in this patient, as well as postoperative chance of development of delirium. Then, sir, yeah. Hello.
How does hypertension produce problems in the intraoperative period? What is actually the problem with hypertension? What are you scared?
So the problem with hypertension is that the reason for development of hypertension is a disturbance in the autonomic nervous system. So there is sympathetic overactivity, and that increases the systemic vascular resistance and increases blood pressure. So and then there is a thickness in the vessel wall, and hence the patient will be relatively hypovolemic, and all our anesthetic drugs causing vasodilation, there'll be a higher and precipitous BP fall in this patient. And since this patient is an elderly patient, there is a decrease in compliance of the venous system. Hence, again, that will lead to a fall in blood pressure.
You know, this patient is a 76-year-old man. So,
yes,
with hypertension, what kind of risk grade will you give this patient?
Sorry, sir?
what will be your assessment of the risk in this particular patient?
Sir, in this patient, sir, the preoperative risk stratification, sir, the surgery as such is an intermediate risk surgery, and this patient, he does not have any history of ischemic heart disease or history of congestive cardiac failure or CVD, or the patient is not on insulin. Patient is not on insulin, or patient does not have serum creatinine value is not high. Hence, the patient would be to RCRI risk of 0.
Okay. What investigations will you be doing?
Sir, in this patient, the investigations that I would like to do would be complete blood count, including HB, platelet count, and total WBC count. Then I would like to do random blood sugar, because this patient, even though he does not give a history of diabetes, this might be a symptom which might have been missed in the patient. Then I would like to check his coagulation profiles, PTCP as well as PTINR. Coagulation profiles can be done. And sir, I would like to do RFT, that is serum creatinine, should be checked for this patient, because of the BPH itself, there could be obstructive uropathy. And other than that, because of his hypertension also, there could be changes in the kidney. Hence, I would like to do serum creatinine. Then I would like to do ECG. A 12-lead, standard 12-lead ECG should be done. This is to check if the patient has signs of left ventricular hypertrophy is there, or left ventricular strain, or dysarrhythmia is present. Then serum electrolytes should be done in this patient, sodium and potassium. Then we should do blood grouping and cross-matching for this patient. And chest X-ray is done. Chest X-ray is to check for LVH in the left ventricular hypertrophy in the X-ray, as well as cardiomegaly, or if you have aortic valve sclerosis, or if the patient has prominent aortic knuckles or increased bronchovascular markings, signs of pulmonary edema. Then, sir, I would also like to do liver function tests for this patient, because I would like to check specifically the serum albumin level. Because serum albumin level, if it is less than 3, it is a high risk for post-operative morbidity and mortality.
You won't be doing any electrolyte tests?
Yes, sir. Serum electrolytes also, sodium and potassium.
Only sodium, potassium, or is there any other?
Magnesium.
Why magnesium?
Sir, because magnesium also, it can precipitate the fall and it can cause TURP, the increase in the symptoms of TURP. So I would like to check magnesium as well.
What increase in which symptom of TURP syndrome?
Sir, the seizures. It can cause seizures.
Okay. All right. You said you will check for BTCT and PT, APTT. Are they going to show any? Isn't it?
Yes, sir. Yes, sir.
Are they going to show anything, any problem in this, or is there anything else which will show some other coagulation problem?
Sir, this patient, we would need to get a baseline value, because there could be coagulopathy that can develop intraoperatively as a result of the procedure itself. Then, sir, if we have to, because the patient is on aspirin, actually we would have to do a aggregometry test. The platelet function tests are better for finding out the coagulation.
Yeah, so probably only a platelet function test can show, which is usually not done.
Yes, sir.
Yes. Okay. Is there any optimization that you will do in this patient before you take up this patient?
For optimization for this patient, I would like to continue his antihypertensive and record the values in the ward, and also we'll have to ask them to inform the value on the morning of surgery. In my pre-op orders, I would ask them to omit ACE inhibitors on the day of surgery. And you can give the ACE inhibitors on the night before surgery, but omit it on the day of surgery. And sir, also aspirin, I would ask to withhold for 5 days before surgery.
You will continue with enalapril on the day of the surgery also, is it?
No, sir, no, sir. I will ask them to omit it on the day of surgery.
Okay. Why?
Sir, because ACE inhibitors have shown to cause refractory hypotension on the induction of anesthesia, so I would like to avoid.
What is your anesthetic plan?
So, in this patient, my plan would be subarachnoid block.
Why subarachnoid block? Why not GA?
Sir, in TURP syndrome, I would these patients we would like to give subarachnoid block because it helps us. There is enough relaxation to the pelvic floor and to the field of surgery for the surgeon if you do regional anesthesia, and also the assessment of our complications such as because the patient is wide awake, the assessment of our complications such as TURP syndrome or bladder perforation can be assessed faster because the patient will either be agitated or they can get restless, which will alert us, or the patient may complain of shoulder pain, again it can alert us. And also regional anesthesia, it reduces the venous pressures and also yes.
Any other reason? You prefer spinal anesthesia?
Sir,
what about the bleeding? Is it higher or less?
The bleeding is less. Yes, sir. The bleeding is less in spinal anesthesia.
Why is it less in spinal anesthesia?
Sir, because there is a decrease in the pressure, sir.
Which pressure?
The venous pressures, the arterial, systolic and diastolic pressures are reduced. Hence, there would be a decrease in bleeding.
What pressure is decreased?
Sir, hello.
What pressure is decreased in spinal anesthesia? What did you say?
The venous pressures or the peripheral pressures are reduced.
Peripheral venous pressure.
Yes,
okay.
Sir.
Right. Any other reason for?
It is.
What about the incidence of DVT? Is that
DVT? Yes, sir. Spinal anesthesia has a beneficial effect on coagulation. So the incidence of DVT is less. It has a neuromodulatory effect on the coagulation profile, so there will be decreased incidence of DVT, and also the patient can be mobilized earlier. Hence.
Okay, supposing your patient says, no, I don't want spinal anesthesia, I want a general anesthesia. Will you comply with it?
Sir, I will try to explain to the patients the particular risks of the surgery as well as the benefit of the spinal versus general anesthesia for this patient. I will explain the morbidity, I'll explain the risk of the surgery, and if the patient is still not willing, then general anesthesia. We will have to proceed.
With the present anesthetics, do you think there is so much difference between spinal and general anesthesia as far as complication is concerned? Is the occurrence of this TURP syndrome that high?
Sir, the occurrence, the mortality and morbidity is only about 0.2 to 0.8% of all.
Is there a difference between spinal and GA as far as morbidity and mortality?
No, sir. They are both the same. GA or spinal, it is the same.
Okay, so that way actually there is no reason for you to push him into spinal anesthesia if he doesn't want.
Yeah, okay, sir.
Okay. Right. Ramdas, would you like to?
Yeah, talking about geriatrics, is there any cutoff age for geriatrics? Or is there any meaning? Is there any meaning in cutoff age? What is the cutoff age, globally accepted cutoff age?
Sir, patients who are more than 65 years of age.
Is there any importance to that age and morbidity?
Sir, there are age-related diseases and age-related changes that occur in the body. Hence, in various systems, sir, the cardiovascular, respiratory, GI, endocrine system, and hepatic system. Hence, there is a role for the chronology, the age of the patient.
You said there is a decline in multiple physiological systems in old age group.
Yes,
what
sir.
is that? What is that syndrome called? That is what keeps him vulnerable to adverse events. His reserve comes to. What is it?
So frailty.
Yeah, it's a frailty. Yes, frailty. How do you assess that?
Sir, the assessment of frailty can be by the phenotype model or by Edmondson scale, or there is a rapid screening tool for assessment of frailty. In the phenotype model, we will have to ask the patient about how fast, the slowness of his pace, about how his hand grip is, or how his mentation is, sir, and if there is any recent weight loss in the patient.
What about Edmonton scale?
Edmonton score, sir, that it is also related to the patient's morbidity. That is also one, again related to slowness of the patient, where the patient becomes.
I think last year's paper there was a question about timed up and go. That is from.
Yes, sir.
What
timed,
is that?
Sir, timed up and go test is when the patient is asked to stand up from his chair. He's asked to walk for 10 feet and then come back and sit down. And if the time is more than or equal to 15 seconds, there is high chance of perioperative morbidity.
Time is? What is the time?
Sorry, 15 seconds, sir.
No, I think it is less than 10 seconds. It's normal. 10 to 20 is 1 point. More than 20 is 2 points. Okay. Right. Good.
What is prehabilitation, Smira? What is meant by prehabilitation?
Okay. So, what is your plan?
Sorry, sir.
You continue. Yeah, what is the plan?
Okay, sir. So, sir, for this patient, now I have decided on my investigations are done for this patient. I've optimized this patient, and on the day before surgery, I would like to ensure that the orders for NPO are written, and I would like to make sure that blood grouping and cross matching is done, and a bed is arranged in the ICU. And on the day of surgery, on the morning of surgery in the preoperative room, I will be reassessing the patient and introducing myself. I would be I would be confirming the NPO status of the patient, and I will check the consent. I will check the consent form. Then I would secure Vibor IV access if it is not present in this patient. Then I would like to pre-medicate this patient with 4 mg IV ondansetron and an anxiolytic dose of benzodiazepine. Given slowly with the pulse oxygen with saturation probe. Okay. And along with that, I'll also give an antibiotic, the antibiotic prophylaxis.
Is it a good policy to give them a anxiolytic or good dose of anxiolytic if you want to keep them awake? Your main point for against GA was that they will not be able to tell you the symptoms of
yes, sir.
TURP syndrome.
Yes, sir. I would like to give. I would give titrated doses, sir, and check the level of consciousness of the patient, and I would not over sedate the patient.
What will be the stage? Is he conscious or is he unconscious?
Conscious.
Conscious. So then, is it really necessary to sedate him?
No, sir. If the patient is not anxious, then I will avoid benzodiazepine.
If you're bothered about the symptom, I think it's better not to sedate. If you're bothered about, not bothered about symptom, okay, you can.
No. But what is the other problem with the sedative? Is there any other problem with the sedative apart from this? If you give benzodiazepines.
Sir, intraoperatively, our problem is sedation. It could also, sir, lead. It is a risk factor for postoperative delirium. Hence, we would not like to give benzodiazepines.
Okay. So you have premedicated. You have taken the patient inside. Okay. You're not taking it. Yes, he's in the preoperative. What?
Yes, sir. So after that, I will check the operation theater. I will ensure that there is that the machine is working. There is working suction. The drugs, both emergency and anesthetic drugs are present. Then I would check the OT temperature. It should be ambient OT temperature should be checked. Then the presence of a working laryngoscope and the drugs for regional anesthesia. Then I would like to check. I would like to assure that there are warm fluids and warm irrigating fluids are available, and forced air warmers are available. Then the table stirrups are present within the OT before I bring the patient inside OT.
Okay, then?
So once the patient is inside OT, I would like to attach the monitors, that is the pulse oximeter, the ECG monitoring, that is lead 2 and V5, and non-invasive blood pressure monitoring and temperature probe. Then once the monitors are in place, I would put oxygen mask via oxygen via face mask, and I would like to give. I would start IV fluids for this patient. Normal saline is what is preferred. Then, sir, once my patient is comfortable, then I would position the patient, lateral positioning for the patient, and I will identify the space that I am, identify the spinal space, and under aseptic conditions, I will clean and drape the area. Then at L3, L4 space, I would first give about, with a 26.5 gauge needle, I'll give 2% lignocaine local, and then I will administer spinal anesthesia via 25 gauge Minky, 0.5% hyperbaric bupivacaine, about 2.5 ml.
Okay.
Sir, it's given slowly, and after the administration of the spinal anesthesia, I will make the patient supine. I will assess the level of spinal, and once I have assessed the level of the spinal that it has reached, I would prefer to keep the level at T10 level, which is the level of the umbilicus. Then I will position the patient with the help of adequate personnel, OT staff.
So you said you will use a hyperbaric solution. How?
Yes,
what is that solution? What is the composition of that solution?
Sir, 0.5% bupivacaine. The hyperbaricity means that it is more than that of the spinal, the CSF, cerebrospinal fluid, because of addition of dextrose.
How is it made hyperbaric?
By the addition of dextrose.
How much dextrose?
8%.
Okay. What is the baricity of that solution? There's only one solution that you use that you should know the baricity. Nothing else. We don't have any other solution. No?
No, sir.
It's 10207. So
Okay.
1.0207.
Okay.
Okay. What is the baricity of CSF?
Sir, I'm not sure, sir.
No, why are you not sure? You said this is hype. CSF is the standard on which you are finding hypo or hyperbaric. So CSF will be?
So 1.00.
No, CSF will be 1.
1, okay.
Okay, right. What is the specific gravity of CSF? Is it more than water, or is it more than water, or is it less than water?
More than water, sir?
More than water. Okay, we'll take it that. Right. So you said you want to make sure the level should be T10.
Yes.
How will you make sure that the level is T10?
Sorry, sir? How
will you make sure that? Yeah, how will you make sure that the level is T10?
I will assess the level, sir, by spin prick.
No. What is your technique you have to make sure that it is at T10?
So by giving a load, so the volume of the drugs that you're giving, that is, I'm only giving 2.5 ml, and then I would also.
Is it 2.5 ml in all patients?
No, sir. But I would like to give a low dose of the drug in all patients, lower limits of the drug.
Okay. Right. Supposing it goes above T10, what is the problem?
The problem, if it goes above T10, is that we would be unable to assess if the patient has had so specific complication like bladder perforation. The patient will complain of abdominal pain or diaphragmatic irritation leading to shoulder pain. So if the level has ascended above that, the patient will not complain of this and we may miss.
Why the patient will not complain about it? Why is it?
The patient will not feel the pain, sir.
Why? What is the nerve supply?
So the nerve supply to, so you're asking the nerve supply to prostate, sir?
Yeah, what is the nerve supply to prostate, let's say?
Sir, the sympathetic supply to prostate is T11 to L2 and parasympathetic is S2 to S4.
Okay. So T11, so why do you want T10?
Sir, because it is easier for us to identify T10.
Okay, what if, but most of the supply to the to the prostate, the sympathetic supply is from a lower level. And even if you give a level up to L1 or T12, you will be able to block all the sensations. Like when you do a surgery for like a laser surgery, you can manage with a level of about T11, level of, let's say, T12 or L1. So the supply to the prostate is only that much. But you are bothered about what is the other problem?
Bladder distension, sir.
Yeah.
Bladder distension is...
Okay. So bladder distension?
Yes, sir. So for that, we would like to keep the level at T10.
Okay. Right. So you have given the spinal. You have made sure it is T10. So what next?
Sir, now I will check once the patient has been positioned, sir. After the spinal level has been achieved, then I would like to position the patient for surgery. For TURP surgeries, the patient is positioned in lithotomy position. And this is done with the flexion at the hip and the knees, and the patient, both the legs are raised simultaneously and placed on stirrup, and the angle between the hip and the abdomen should be better if it is obtuse, that is about 80 to 100 degrees. And I would also like to adequately pad all my pressure points and also ensure that there is no overextension or flexion of any of the limbs. Then also, sir, I would like to properly cover this patient, and post-air warmer will be kept in this patient. Then and I will assess the hemodynamics of the patient once the patient has been put into lithotomy, and then I will ask the surgeon, I will communicate with the surgeon and ask them to start the procedure.
What's the problem with this lithotomy position? What problem do you expect?
Sir, the lithotomy, the problem will be in venous return, sir. First, there will be an increase in the venous return, and because of that, there will be increase in the preload. And if the patient has a poor cardiac function, the patient can have cardiac failure. Yes.
But you have just given a spinal. You just given a spinal. What happens to the preload then?
Preload has reduced.
Preload would have come down or gone up?
Yes, reduced.
Yeah, so this is a good position, isn't it?
Yeah. So there could be a decrease in, because of there could be venous stasis in this patient because of the position. And also there will be the pulmonary compliance is reduced because of this position. There could be a movement, shift of the diaphragm upwards, reducing the vital capacity of the patient, reducing the pulmonary compliance. There could be finger entrapment that can occur, or there could be nerve injury. That is either the common peroneal nerve, or the saphenous nerve, or the obturator nerve.
Femoral nerve?
Femoral. No, sir. No, sir. If it is extreme flexion, then yes, femoral.
No, not flexion, not flexion. If your abduction is small, you can have femoral nerve because you will stretch the inguinal ligament over the femoral, and you will have. Okay, right. So how will you prevent this?
Sir, I will take care while lifting both the legs that the abduction is only about 30 degrees to 45 degrees from midline. I will prevent over abduction and there will be adequate padding of all the pressure areas, the lateral or the medial side of the knee, as well as then also the flexion between the hip and the abdomen also, about 80 to 100 degrees. I'll keep these positions. If these positions are kept, then there's less chance of nerve injury.
Okay. The surgeon starts operating.
Yes, sir.
What are you looking for? What problems are you looking for?
So when the surgeon starts operating, I will make a note of the resection time, of the start of resection time, and then I would also, the problems that we would be considering intraoperatively, our problems would be that of TURP syndrome can occur intraoperatively, or there can be bladder perforation, or there can be hypothermia, or there can be coagulopathy that can occur in this patient. Then, sir, so I will be watchful.
Bladder rupture, is that such a common occurrence?
No, sir.
How does it occur? How does it occur?
So because of over-distension of the bladder, over-distension increased pressure, as well as because of the instrumentation of the surgeon himself.
Okay, basically it's a surgical fault.
Yes, sir.
Okay. So what else? What else are you looking at?
Then, sir, I would watch for how much of the irrigation fluid is used, and also I would check the hemodynamics of the patient. I would keep assessing the mentation of the patient. I will look for the warning signs, if any.
What are the usual classical warning signs given, at least in the books? That happens. What happens when the TURP syndrome starts?
The agitation and restlessness.
The olden books, old books, all of them say something else, which heralds the beginning of. There's a yawning is something that starts. That is something that the patient starts yawning. Then you think of TURP syndrome. Because it's again fatigue which brings on the yawning. Okay. Right. What about bleeding? How will you assess the bleeding in this patient?
The assessment of bleeding as such, it is difficult to assess the bleeding, but we do look at the resection time and try to see how much it is considered to be 2 to 4 ml per minute of resection time, or about the gram of the prostate, the volume of the prostate that is removed, about 15 ml per gram of prostate that is being removed. Then, sir, I would also look at there can also be radioactive labeling of the RBC or albumin. Then, sir, also there is...
is that something that you do?
No, that's not something. Then,
okay.
Sir, we can look at the hematocrit of the irrigating fluid, and based on that, the hematocrit of the irrigating fluid by the patient's hematocrit into the volume of irrigating fluid, that will give us also an estimation of the blood loss.
Okay. Does it really help you? Have you done it?
No, sir, I have not done
it. Because it's difficult, because it's a very dilute hematocrit, and none of our usual hemoglobinometer will show you how much it is. You have to use a different kind of hemoglobinometer. Okay, right.
Yes.
So it's not practical. So what is practical for you to assess the blood loss?
So the resection time?
Yeah, that's an approximation. It's never correct.
Sir, hemoglobin of the patient himself?
Yes, frequently check the hemoglobin, because there's something else happening. It's not just a loss, there is something also happening in the patient. What is that?
Sir, coagulopathy.
No?
So warning, like sir, we'll check for pallor, sir, pallor.
No. There is so much fluid being absorbed, isn't it?
Over, yes.
So there is dilution taking place. You are losing
Yes,
blood and also dilution taking place. So what matters is the final hemoglobin as a due to the dilution as well as the loss. If you have to assess that, you can only assess the blood hemoglobin of the patient, which you should be doing every now and then. Okay, right. So what else? What else do you think is the problem?
Sorry, sir.
Where do you think there will be more blood loss? In which patients do you expect more blood loss?
Sir, in patients who have a large prostate, who have if the volume of the prostate is large.
Large means how much?
So more than 45 gram of prostate volume.
Okay, right. Maybe 60. Okay. Then?
If the patient has had recurrent UTIs, then there is chance of more bleeding. Then, sir, based on the surgeon's technique himself, increased intravesical pressure.
Intravesical?
Pressure, sir. Within the bladder, sir.
Yeah, how does it affect the bleeding?
So, over distension of bladder, there can be more chances of bleeding.
Okay. Anything else that can produce problems of bleeding in prostate cases?
Bacteremia, sir.
Bacteremia, you said already about this thing, about the infection. So coagulopathy possible?
Yes, sir. There could be dilutional coagulopathy in this patient because of the urokinase, which is released by the prostate. It will convert plasminogen to plasmin, and which in turn will cause increased fibrinolysis.
Okay.
Then, sir, sir, the prostate itself, there is thromboplastin, which again, if it goes into circulation, there will be DIC.
No, more than DNC, consumption coagulopathy.
Yes.
Okay.
No.
So, what will you do for this problem with urokinase?
Sir, I would like to give tranexamic acid.
What is that?
So that is to reduce antifibrinolytic agent is given. 1 gram can be given.
How does it act?
So by decreasing the the fibrinogens of.
You're guessing.
I'm not very sure.
Okay. It's an antifibrinolytic, which is something similar to plasmin. So it's a competitive inhibitor. It will go sit at the same site as plasmin, and thereby it doesn't allow plasmin to come in. For that purpose, there is one important time for that to be given. When should we give it? If it has to act.
I don't know.
I told you I've given you the clue. It's a competitive inhibitor.
So before the insult has occurred,
before the bleeding starts.
Okay. Before the bleeding starts.
Okay. Once the bleeding starts, once urokinase comes, then no point, not much of point. Okay.
No.
What are the other antifibrinolytic you know?
Sir, aminocaproic acid.
Full name is not aminocaproic acid.
Epsilon aminocaproic acid. Epsilon aminocaproic acid.
What else? Aprotinin?
Yes, sir.
Okay, right. Okay, so coagulopathy is one problem. So that's about bleeding that you can have. What is the other problem that Ramdas, would you like?
Yes, yes. What are the other problems you can have? Yeah, same question.
So the other problems that we can have is TURP syndrome can occur, sir, intraoperatively. TURP syndrome is a combination of symptoms which occur because of iatrogenic hypervolemia, and that will lead to hyponatremia and hypoosmolality. And the symptoms can be varied. The symptoms in the CNS, the patient could be restless, the patient could be agitated, restless. There could be seizures, or in the cardiovascular system, there can be dysarrhythmias that can occur, or the patient can go into pulmonary edema, hypervolemia, pulmonary edema. Then, sir, even in the patient may have nausea, vomiting. Then, sir, metabolic. There can be metabolic derangements. There will be hyponatremia. There will be hypoosmolality and metabolic acidosis.
Which is the most commonly used irrigation solution?
So the most commonly used is 1.5% glycine.
What is it? What is it? What is glycine?
Sir, glycine is it's an amino acid, and it is a hypotonic solution that we are using with an osmolality of 230 milliosmoles, and we are commonly using this because it gives us it is transparent. It gives us good vision intraoperative during the surgery.
Well, what are the problems unique to glycine, which is not very peculiar to glycine?
Sir, in glycine toxicity can occur, sir, and there can be hyperammonemia, hyperglycemia can be there, and the metabolites of glycine is glycolic acid and oxalate and ammonia. Because of glycolic acid, there can be lactic acidosis. Because of oxalate, there can be the renal failure because of deposition of oxalate, or because of hyperammonemia, the patient may have nausea, vomiting.
What else can it produce?
And transient blindness can occur, drowsiness.
What is the mechanism?
Transient blindness is because of the interruption of the retinal neurophysiological disruption. It is the inhibitory action of glycine on the retinal transmission, which is why we would have transient blindness. It is just transient. It is you only need to reassure the patient.
What is the normal levels of glycine?
13 to 17 mg per liter.
Okay. So when does it start producing problem?
Sir, if it goes beyond 17, sir, there will be issues.
Is it? Okay. What happens is that correlated with glycine levels. All patients with glycine, do they get ammonia hyperammonia?
Sir, hyperammonemia is the levels of ammonia is more than 100 millimoles per liter. That is when the symptoms of toxicity develop. And if the levels may go even beyond 500 millimoles, and to treat it,
will all develop that? That is a question. Will all patients develop that?
No, sir. Not unless the ammonia levels are high enough to cause toxicity symptoms.
Why? Why? Who is more susceptible for hyperammonia? How is ammonia metabolized?
Sir, ammonia is metabolized in the liver, the urea cycle. So those patients who have hepatic dysfunction, they will be more prone to develop.
Okay. So, anything that is there any other catalytic amino acid which is important in the ornithine cycle? It's urea cycle, otherwise known as ornithine cycle.
Yes, sir.
So there is a catalytic.
Arginine, sir.
Yeah, if you have arginine deficiency, again. Okay.
Okay. Yes, sir.
Right. Normal levels of ammonia is how much?
That's a normal level.
No, 11 to 35 single millimoles per liter. Okay.
Yes.
This TURP syndrome, is it something that happens only in TURP or is there in some other surgeries also? You should be
hysteroscopy.
Hysteroscopy. Okay. Anything else? What about, there are so many other urological surgeries where you pour water, long period surgiscopy, it goes on for a long period. Sometimes the PCNL also takes hours and hours. Again, same thing can happen.
Yes.
And the hysteroscopy, where that is TCRE, is another surgery where you can have TURP syndrome.
Yes.
You said about hyponatremia and hypoosmolality. Which is more important? Troublesome.
Sir, hypoosmolality is more important.
Why?
Because there will be hypervolemia will be caused in the patient because of low serum. It's a dilutional process. Even if in hyponatremia, even if it occurs, it is not because it's because of dilutional hyponatremia that it is occurring.
So if you have a patient who is hyponatremic and his osmolality is normal or near normal, can you leave him alone?
No, sir. If the patient has hyponatremia, then based on what is the level of the hyponatremia, if the patient
he is hyponatremic but asymptomatic. His osmolality is near normal.
Then we would treat the hyponatremia.
Is it necessary?
If it is if it based on if it is like a chronic hyponatremia or an acute hyponatremia.
This is not chronic hyponatremia. When do you call it chronic hyponatremia?
If there is a if this is acute. No, not sure. If it is an acute event like in this case, then we would like to treat the hyponatremia.
No. When do you call it chronic hyponatremia?
The exact time I'm not.
When it is more than 48 hours, you call it chronic hyponatremia.
No.
But this is a acute hyponatremia, isn't it? So,
Yes, sir.
in that case, if the hyponatremia alone is there, patient is asymptomatic. Is it necessary to give hypertonic saline?
Sir,
Yes
no.
or no?
No.
Yeah. The
No.
right answer should be no.
No.
There
Yes.
is no need.
No.
If it's a symptomatic patient, yes, definitely. But
Yes.
asymptomatic, because why? This is what I'm asking. Why hypoosmolality is more important? What is hypoosmolality?
Sir, because the hypoosmolality will cause hyperolemia and circulatory overload in this patient, which is why.
No, we are not talking about circulatory. Hypoosmolality per se. What does it do? What happens to the brain?
Cerebral edema can occur in the brain. Yes.
Cerebral edema. How does
Edema
it occur?
can, because of the shift, sir.
How does
of
it
the, so because of the decrease, the shift of the osmotic, the gradient, the hydrostatic pressure gradient and the osmotic pressure gradient, there will be more volume. More volume will shift into the brain parenchyma, causing edema, cerebral edema.
Yeah. So water goes inside the cell.
Cells.
Okay, cells. Okay, so you have cellular edema. So that happens mainly when you have a hypoosmolality. That's why it is important that you don't have hypoosmolality. What is the normal osmolality?
Sir, 295, sir.
Exactly 295.
So 280 to 295.
Yeah, it's a range.
Yes.
How is it maintained in that range?
So the different electrolytes of sodium, potassium chloride.
Yeah, but what maintains it in that range? What is the mechanism?
So the Nernst equation, sir.
No. There is something in the hypothalamus. What is it?
So the antidiuretic.
How does body control the osmolality? It's by which active peptide? Which acts on the kidney and then makes sure that...
Renin. Vasopressin.
Yes, okay, I didn't vasopressin. Okay.
Vasopressin.
Yes, okay. It acts on the which receptor in the kidney?
So the V2 receptor.
No, okay,
V2
right.
receptor in the kidney.
V2 receptors in the kidney, correct. Okay, right. Okay, so that is the way it is maintained, right? So what will you do to make sure that this doesn't happen? You don't have any hypo, or in case it happens, how will you treat it?
So, in case we are suspecting hypoosmolality, we would treat it with diuretics.
Will you give diuretic to a patient with hyponatremia?
Because our primary problem is the dilution, it is, and also the hyponatremia is a dilutional one. It will not cause much change to the sodium level per se, so I will give.
You are giving a natriuretic, diuretic. It will definitely take off sodium.
So the effect is not as much, sir.
No, do you have any other agent that can be given as a diuretic, which doesn't produce much of natriuresis?
Mannitol can be given, sir.
Okay. Is there any good thing that if you give mannitol, what happens to the osmolality?
They will cause, there is an increase in osmolality.
Oh, so isn't that better?
Yes, sir.
Okay. Right. So other than diuretic, what else will you do?
Sir, I will stop the, I will ask the patient, ask the surgeon to stop the surgery. I will restrict my fluids, which I'll be giving.
Is he going to listen to you straight? You stop the surgery.
Achieve hemostasis and conclusion of
okay. Then,
yes, then I would like to restrict the IV fluids that I am giving for this patient. Then I would also like to check how is the mentation of the patient, and as well as the hemodynamics of this patient right now, and if anything has to be supported, if there is any need for any cardiac support, and then I would give vasopressors or inotropes can be initiated in the patient. Along with that, I will give furosemide, or mannitol.
Okay, that's all. What about hyponatremia?
Yes, sir. Hyponatremia also, I would like to take I would assess the ECG. The ECG, if I will see if the ECG has any abnormality, if there is any widening of QRS into QRS. At the same time, I would also like to draw blood for arterial blood gas analysis, mainly to look for sodium levels as well as serum osmolality levels. Sir, and until then, I will support the patient. And if there is any ECG abnormality that I am detecting, and if the values has come to be low, then I will supplement with, I will give the patient hypertonic saline.
How much hypertonic saline? Supposing the value comes as 115.
The 3% hypertonic saline can be given to this patient up till the value has reached 130 milliequivalents.
140.
130. 130. And symptoms, and a patient is asymptomatic. Until the patient is
115, do you think there will be symptoms?
So the patient can have nausea and somnolence at 115.
And ECG will show? Any changes?
ECG will show wide QRSs, ST elevations, and ectopic.
Okay. So definitely it needs treatment. Okay.
Yes,
what is the immediate target?
The immediate target is above 120 milliequivalents.
120. Okay. Yes. Okay. So how will you achieve that?
So by giving the hypertonic 3% hypertonic saline is given at not more than 100 ml per hour to increase.
Why 100 ml?
Sir, I am worried of giving it the hypertonic saline too fast, because there could be osmotic demyelination syndrome.
Okay, osmotic ODS happens when?
So if I'm giving it,
why does ODS happen?
So because because of giving the hypertonic normal saline is given very fast, so the solutes within the brain, they will within the cells within the brain, the solutes are because of the osmotic gradient, they are pushed out of the brain cells, and because of that, there is osmotic demyelination, a shrinkage of the brain cells.
Why should that happen? Because it's acute hyponatremia. It just started swelling up, and then you give sodium. It will only push back the water. Why should the solute come out?
So if it is given to rapid correction.
Yes, that is only in chronic hyponatremia. Why does it happen in chronic hyponatremia?
So because the cell size is not as big as it is in acute brain cell size, the brain solutes within are not as big as it is in the acute case.
No. It's because there is a compensatory mechanism which is at work. After hyponatremia strikes, there is osmoles are excreted out of the brain cells. It goes out and it produces a balance between the extracellular fluid and the brain cell. That takes time. It takes more than 48 hours to happen. And if you give fast, yes, it will produce problem. But you are treating an acute hyponatremia which has occurred in front of your eyes in half an hour. There should not be any reason for you not to give fast. You can give it fast.
Okay.
You are allowed to give in the first 4 hours even at a rate of 2 millicoulombs per kg, 2 millicoulombs per hour. Okay, you can raise it by 2 millicoulombs per hour. So in 3 hours time, you should be able to reach 120. How much should you give for that?
So how much volume?
How much of 3%? How will you calculate?
So the body weight into the desired sodium minus the patient's sodium.
Body weight? Body weight?
The total body weight into the desired sodium level that we need minus the patient's current sodium level.
Why you give 100% of body weight into 60%? That is what you want to do. It's only extracellular compartment you want to replenish, isn't it? So it will be body weight into 60%. Okay, so that's 0.6 into body weight is your extracellular water. So for a 50 kg patient, give 30 liters.
30.
Okay.
Yes.
So if you calculate at that if you give twice that amount, you will actually. So if you calculate body weight into 0.6 into 2, okay, if you give that much volume, you will actually raise it by 1 millicoulombs. 1 millicoulombs. So if you want to bring it up by 2 millicoulombs, you have to per hour. That means you can give 2.4 ml. 2.4 ml per kg you can give, which is almost 150 ml. Okay, so you can afford to give 150 ml in the first thing. In case you don't have hypertonic saline, what is the other agent that you can use?
Normal saline can be used.
No, never say normal saline. You are doing so well so far. Don't bring it. What will happen if you give normal saline? You will only expand.
Again, hypervolemia.
Yes. And it will not correct sodium. Is there any other agent which has high concentration of sodium, high osmolality, which can be given? It is always available in most of the theaters.
Is given in acidosis?
Yes.
Acidosis.
What do you give in acidosis? I don't give, but you may give.
Soda, bicarbonate.
Bicarbonate. How much is the osmolality of bicarbonate? 8.4% bicarbonate. How much is the osmolality?
I'm not sure. Yeah, so 2000.
What is the osmolarity of 3% saline?
Sir, osmolarity of 3% saline is 1025. No, sorry, 513. 513 milliosmoles.
513. Is it? 513 is the sodium level.
Sorry, sir. It's 1025 milliosmoles per liter.
So 513 into 2 is 3% saline. What about sodium in bicarbonate? 8.4% bicarbonate. 84 is the molecular weight of bicarbonate.
Not sure. 2000, sir?
1 ml of 8.4% bicarbonate contains how many millimoles of bicarbonate and sodium?
No, not sure.
Why are we giving 8.4%? Because 1 ml is equal to 1 millimole. That is why this 8.4% is being used, isn't it?
Okay.
It's easy for your calculation. 1 ml is 1 millimole.
Okay.
So it contains 1 millimole of sodium, 1 millimole of bicarbonate. So it has 2 osmol per ml.
Okay.
So 1000 ml, 100 ml contain 200 milliosmoles.
Okay.
Okay. So, seeing soda bicarb is something that can be given soda bicarb than 3% saline. Okay, so it can be used.
No.
Okay.
No.
Right. I think I've confused you quite a bit.
No, sir.
Is the time okay, Dr. Rajesh? Is the time okay?
Yes, sir. Yeah. So how many more minutes is expected?
There is one more session, no?
Yeah, we have one more session.
This can continue. This can continue for. But there is one more session. That is why I asked.
If you want, we can continue.
We can continue for the next 10 minutes and hand over to Dr. Mubarak, sir.
Okay.
Rajesh, just I would like to give.
Mubarak, sir, anything?
Regarding the say now it is 1.5 hours of discussion on a TURP case. A candidate never gets more than 30 minutes for the
I think that's
for the teaching purpose it is fine. It is fine.
Yeah.
But for the coming DNB exam, the maximum time obtained for a candidate for a case is 15 minutes. So whatever output the candidates gets or whatever questions you can ask for the coming exam is only 15 minutes. So we should try to restrict our discussions and produce maximum output in the desired time. Of course, this was very fantastic discussion and all, but the time factor also we should train to the students. So that's just a comment I want to make. So it's when it is
the aim is to generate the maximum questions from
that is true.
Yeah.
But the candidates should also be trained. Should be trained to.
We are the culprits.
Yeah, should be trained to answer or give maximum inputs because the questions will be bombarded and coming in fast output. So the candidates should be trained to give fast output also. Okay, sir. This is my comment.
Because today we had 2 experienced faculties and the questions are really good. That's why
that is true. That is true. But when it comes to exams, the candidate should be trained to give fast answer because they have only 15 minutes for a TUR case discussion maximum in the coming exams.
That is
Yeah.
Dr. Mubarak, that is correct. That you should explain it in your next talk. Your thing, because
Okay. Please continue, sir. Sir, please continue. Just made a.
That's why I said we are the culprits. We thought we'll make it also a teaching session so that we can teach them so many things. That is the whole idea.
Yeah, that's right. Yeah, that is the idea.
I mean, I'm sure that
Okay.
Definitely.
We'll wind up the session then. We'll continue with the next session because it's already.
You can continue, sir. No problem. This time I'm telling we should concentrate the candidates on the time factor also. That's what my message.
That is correct. Yeah, that you are very correct about it.
Yeah, we also got they should also compliment the candidate. The candidate also was forthcoming with a lot of answers. That's what also made us actually ask some more questions.
Yeah. She was actually answering fantastically, but after 1 hour, the candidate's stamina also becomes lesser, and the output. And I think she's making mistakes now towards after 1 hour. The first 1 hour, she was energetic and very well answering. Maybe due to the tiresome questions. And your questions were very specific, the values, everything she was answering well. She should be given a very good applause for her answering also.
Yes.
Despite of this lengthy session of about 1.5 hours. Okay, sir. Please continue, sir.
Okay, right. So, Ramdas.
Yeah. So shall we wind up? Dr. Vinod is fine, no? She has done well. And
she has done well. I'll ask, lastly, I think I'll ask one thing.
Okay.
How will you, what are your guidelines for anyone to prevent TURP syndrome? What should be your guidelines? We'll stop with that.
Yes, sir. So for prevention of TURP syndrome, we will have to make sure that the resection time is reduced to about maximum up to 60 minutes to 90 minutes of resection time, and also the as well as the volume of the prostate. We'll have to keep an eye on how much of the volume of the prostate is resected. Then the height of the irrigation fluid, that is limited to 60 centimeters. Then perioperative hyponatremia, if it is present in the patient, and then that in turn can be a precipitating factor for intraoperative and postoperative TURP syndrome. Then, sir, if the patient is has a large number of open prostatic sinuses, that also can lead to TURP syndrome.
Okay. Why did you say 60 centimeters?
So 60 centimeters, it is based on the irrigation fluid hydrostatic pressure on the because 60 centimeter of irrigation fluid height will be the maximum hydrostatic pressure that that is present at the cellular level, so that there is less amount of absorption of the fluid.
Did the surgeon think of 60 centimeters because that? The surgical choice, 60 centimeters, or they would like to have more. But why 60 centimeters?
Because we would like to restrict the hydrostatic pressure.
That we would like to.
Yeah.
60 centimeters was chosen because with their irrigating system, you get 300 ml per minute flow, which is necessary for them to have a clear visibility. That is the reason they have chosen. But the problem is that they would like to go more, which is where you should put your foot down and say no. Okay. So probably up to 70 centimeters is fine. You can give 10 centimeters more to him, but don't say anything more will produce more problem. Okay. Right. Thank you. You did wonderfully well. Yeah. I'm sure you will look after a TUR patient without any problem. You will be a good anesthetist.
Thank you.
Thank you.
Okay, well, you are done really well.
Thank you, sir.
Vinodhan sir and Ramdas sir, can we give A+ to her?
Definitely.
Yeah, definitely. Okay.
She deserves.
Dr. Binil.
We will award her a certificate on next Saturday.
Yeah. So now we will go to another. Thank you, Dr. Smera.
Thank you, sir.
Thank you, Vinodhan sir and Ramdas sir.
Right.
Shall go to the next session.
Thank you.
Thank you, sir. Right. So another important session from Dr. Mubarak sir. Sir, as you know, is the HOD, Professor and HOD, Calicut Government Medical College, and then is an experienced examiner. So he is going to give some important tips and how to face a practical exam in the era of COVID. So over to Mubarak sir.
Dr. Rajesh, I want to share the screen. Just I'm trying to for that.
Yeah, okay, sir. Take your
Sir,
time.
just share the screen, sir. You'll be able to share.
Share button.
I'm not able to get my desktop in this.
Hello.
Just can you just
Sir, class proceed.
is it okay?
Sir, it's not visible.
Is it not visible? Not visible?
Yeah.
Not yet.
Not yet.
Sir, just open your PowerPoint.
PowerPoint is open.
Then just minus it and just press that green button, share screen button, and select that PowerPoint.
Just
Double click on the PowerPoint and share it.
Share screen open. Share screen. I have clicked now.
Then you have to select that PowerPoint from the window, pop-up window. The pop-up window.
Is it visible now?
No, sir. You didn't share anything, sir, till now.
Okay. What is it happening? I am visible. My screen is not visible yet. I will click on the share. I am just clicking on the share screen.
Green button press ചെയ്യ് സാറേ, അന്നേരം ഒരു വിൻഡോ വരും. ആ വിൻഡോയിൽ ഓപ്പൺ ആക്കിയിട്ടുള്ള പവർ പോയിന്റ് വരും.
Okay.
Sharing.
Now it's okay. ഇപ്പോ കിട്ടുന്നുണ്ടോ?
ഒരു സെക്കൻഡ് വെയിറ്റ് ചെയ്യ് സാർ. ഇറ്റ്സ് കമ്മിങ്. സ്റ്റാർട്ടഡ് സ്ക്രീൻ ഷെയറിംഗ്. ഒരു ഡിലേ ഉണ്ട്.
ഡിലേ ഉണ്ടോ? മേബി
ഇല്ല, ഒന്നും ചെയ്യണ്ട സാറേ, വരും അത്.
കുറച്ചും കൂടി റേഞ്ചിലുള്ള സ്ഥലത്തേക്ക് മാറണോ? Let me try.
ഇല്ല, കുഴപ്പമുണ്ടാവില്ല. ഞാനൊന്ന് സ്റ്റോപ്പ് ചെയ്യാം സാർ. ഒന്നുകൂടെ ഷെയർ ചെയ്യാൻ പറ്റുമോ?
ഓക്കെ, നോക്കാം.
സാർ ഒന്നുകൂടെ ഷെയർ ചെയ്തേ. സെയിം.
സ്ക്രീൻ ഷെയർ ചെയ്തു, ക്ലിക്ക് ചെയ്തു, ഷെയർ. ഓക്കെ.
Yes, coming sir. Perfect.
Now it's okay.
Okay. Video disturbance ഉണ്ടോ? Audio disturbance ഉണ്ടോ?
ഇല്ല, എല്ലാം ഓക്കെയാണ് സാർ.
Okay. Am I audible now? Is it okay, Binil?
Audible, sir. Perfect.
Okay. Thank you. Yes. Sorry for the delay. Okay.
So after the fantastic lecture on anesthesia machines by Dr. Gurudutt and the lengthy discussion of TURP syndrome by Smera, guided by Dr. Vinodan and Dr. Ikirandas, this is not a scientific topic. This is just meant for the postgraduate students who are appearing for the exams right now. They wanted some tips regarding the exams in the current scenario. The current scenario has changed a lot, we all know, because of the COVID pandemic and all. I'll just go through the details of the this mark sheet of the Kerala University of Health Sciences for MD anesthesiology. We are having, after theory, we have practical exams. For that, we have a long case of 150 marks and 3 short cases of 50 marks each, making a total of 300 marks for the practical block in anesthesiology MD. And we have Viva OSCE of 4 stations of X-rays, ABGs, ECG, capnograph, PFT of 1 station. The second one, drugs, anesthesia, circuits, critical care, IV fluids and all. Then anesthesia machines and circuits, equipments. Then a 4th station of cardiopulmonary resuscitation, airway management. And a 5th item has been added recently now for logbooks of all 4 or 20 marks constituting of 100 marks in Viva. So there is no separate minimum for Viva or practicals. At aggregate of 50% is the pass mark. And for diploma anesthesiology, we are having 1 long case and 2 short cases. That is 100 marks and 50 marks each of short cases, constituting the same practicals of 200 marks. And the Viva station and logbook are similar, same, and total marks is 300. And 50% aggregate is the pass mark. And previously for the DNB anesthesiology, we had 4 cases. Previously we had long cases and short cases, but it has been then changed to 4 cases of equal marks of 50 marks each, constituting 200 marks. And 5 Viva stations it was previously there, with drugs, fluids, anesthetic machines, resuscitation and investigation, similar to the Kerala University pattern which I discussed. And there was an additional 5th station for research methodology, research advances and communication skills of 20 marks. So this was a pattern going on. And the time duration, the long case we usually give 30 to 45 minutes maximum, and short cases we give 15 minutes, 10 to 15 minutes. And Viva stations are of 5 to 10 minutes, 10 minutes each, like that we are going. And it is in this time duration the candidate has to perform best and the examiner has to extract the knowledge. So when the candidate is well prepared, the answers will be spontaneous and they will get more chances for better answers and they can score more. And we have all the specialties. We are having physical patients cases for the exams, and we are doing. And 2 viruses now has come. First one, the Nipah virus, and then the COVID virus. The Nipah virus was stuck up with, though mainly in Calicut. It has also encroached our exams, practical exams. Not only in Calicut, the whole Kerala University practical exams in several specialties, including anesthesia, was affected in 2018 when the Nipah outbreak came. Mainly because the examiners from outside were reluctant to come to Kerala, especially to Calicut or even to other centers in Kerala. And there were hardly patients in the hospital, especially in Calicut and all. And the examiners coming in the morning, agreeing in the morning, in the afternoon they are telling they can't come because of fear of Nipah, and the exams were postponed. And it was a very tough time to get the examiners, not only in Calicut, in other centers in Kerala. And we didn't have any relaxation regarding the case, or we didn't have any opportunity to appoint local examiners from within the state, or to conduct the exams without cases. So we had a very tough time, but we managed somehow to get the exams. And in Calicut, we had to shift the centers even to other colleges because of Nipah. So it was, though it was confined to Kerala, it has affected the whole Kerala's exam scenarios in that case, in that season. And we thought by that time the Nipah was over and we went back to normal, and we had, in 2019, we had the regular exams, MD, DNB and all, and we were comfortably going back in the same situation. And in 2019, the coronavirus came and the condition became very worse. And it was not confined to Calicut or Kerala. The whole global scenario of coronavirus affected and ended up in lockdown situation. There was no patients. It was everywhere in the state, not only in the state, country, globally. So no wonder it has affected our exams also. So the course was over. The candidates were waiting for exams. There was no idea of what to do for exams. Both the universities within the states as well as the national board has been postponed the exams, and the candidates was perplexed what to do, and the universities had no idea how to conduct the exams, because there was no relaxation or anything so far. And clinical exam, there was a lot of discussions and all the problems, and somehow it has to be tackled out. And the Medical Council of India in May last and June came with 2 orders to tackle the situation because of this which made the full stop to the indefinite status of the exams. So the first one, the first order was on May 15, and the second one came in June. So with these two orders, the Medical Council of India, in the special scenario, allowed to avoid. It is stated that due to COVID pandemic, most medical colleges have expressed the difficulty in adhering to the existing regulations to examine the candidates by giving cases. So since the objective of practical examination is to ascertain skills relevant to the specialty, and alternative methods of skill evaluations with simulations, case scenarios, etc. may be used in lieu of clinical cases when it is not possible to have cases for the examination held in 2020. And it was only a one-time exception provided by the MCI in view of the COVID pandemic to conduct the exams without having patients. And another order also came on 22/5/2020, in which the problems of getting examiners, like in Nipah period, and there was regulations in traveling from interstate travels and all. So the MCI gave another order to appoint examiners within the state to conduct exams, so that the 2 examiners from outside the state has been relaxed. So we got a legal permission. So with that, the universities and national board started having examiners without examinations scheduled, with examiners within the state and examination without real patients and scenarios. And so this was it was legally permitted. And so then but the MCA has specified this is only for the current exams in 2020 only, in view of the prevailing COVID pandemic. And we did the exams without cases and with internal examiners, both for the different universities across the state, and even MCI inspections was done during this pandemic exam, with online inspections of these case scenarios, and it was permitted. But the coincidence, and the national board devised a different pattern of exams. Like instead of having this long case and short case, the national board converted into an OSCE based exams in which there were no patients. So the OSCE, it was initially only the candidates who are having the diploma or who are primary candidates, that is, who are not having MD, were permitted to appear for the exams. Others were denied chances during the first chance, probably because to restrict the number of candidates and to get the candidates passed out for those who are deserving, because DNB will make a difference to them. So they devised an exam pattern without patients based on this MCA rule, and they devised an OSCE based exam with
5 minutes OSCE, 25 questions of OSCEs of 5 minutes each, with constituting a 150 marks, and another session of Viva OSCE as the previous one, 4 stations, and an afternoon cases clinical scenarios. That is 2 cases. That these OSCEs were only 5 minutes. You cannot answer more than 5 minutes, and the clinical scenarios were restricted to 15 minutes each, with one scenario which is common to all the centers was provided by the national board, and the examiners were asking questions on that. And another examination without clinical case without a patient by simulators or volunteers were provided in each centers according to their convenience. And for these 2 clinical cases, they awarded 150, 30 marks to make a total of 150 marks. That is in 150 marks for OSCE, 40 marks for Viva, and the rest for these clinical cases. And they made a total, out of total 300, they made a aggregate 150 marks as the pass marks. And though the exams was conducted in this manner, the COVID continued, and they didn't even, and the lockdown was relaxed, and people started traveling. But the COVID is continuing, and there was plus and minus for this patientless exams for the candidates as well as the administratives. So since the COVID is continuing and there was relaxation, now we can and many specialties conducting exam without a patient at all, there was so much criticisms. So the universities as well as the national boards started changing, gradual changing the scenario, though, and the MCA has been dissolved and it has been NMC, though there was no fresh guidelines for those things. The universities has decided to continue in almost the same pattern with a touch of patients. That is, in Kerala University of Health Sciences, that is KUHS, we did the exam last time now in 2020 with 1 patient at least for cases and the other scenarios. So in anesthesiology, we did long cases with real cases, and the other short cases and all with scenarios. So there was an instruction by the university to have at least 1 case as a long case, as real case, and the other scenarios as previously. So also the national board is now coming for the next exams. That is coming next week. The exam is coming, and the date is announced as 4th March. So the national board also has devised it in a similar manner. And they have assigned 10 to 12 candidates per center, and across the country there are more than 40 centers, and they have been asked to maintain social distancing norms, offer safety precautions, and for the examiners as well as the candidates has to follow the directions of the state and central governments regarding the COVID protocol, pandemics, the tests and all, depending upon those things. And the examination has been modified into a pattern to include ward rounds apart from the previous pattern. So in the ward rounds, they have instructed the centers to have real patients. So, but the time is very limited. In 1 to 1.5 hours, you have to do the ward round for 10 to 12 candidates. So you get hardly 10 minutes only for discussion. So it means that patients, just having a patient touch either by history or so, but we should give real patients, but they don't have any time for a detailed examination or detailed evaluation. So the complaint of not having a patient at all in the exams is being rectified by the national board as well as the Kerala universities. So the newly designed pattern, so the exam schedule, the candidates has to report at 8 o'clock. That is and attendance, all those things will be formalities. And 8:30 a.m. the candidates, the center coordinator will brief the candidates regarding the current pattern of examinations. And already this pattern has been given as a webinar by the national board to students in the last week, a few days back. And after distributing the answer sheets and the OSCE sessions, previously there was the OSCE sessions time was 5 minutes and it was of 6 marks. Now they have reduced the OSCE sessions to the duration has been reduced to 4 minutes, but the questions remain same, and the marks has been reduced from 8 minutes to 8 marks to 6 marks. So in 2 hours, the time, the 25 OSCEs will be over by 11 o'clock. And immediately after tea break of 15 minutes, immediately they will be taken to the Viva stations as done in the previous exams. And after the Viva stations, they will have this ward rounds. So that is a new thing added with real patients, but the time duration is only maximum 1 to 1.5 hours. So within that time, the candidates has to be examined for these ward cases. So we can imagine the time limit. Your output should be only in this time. The OSCE, you cannot answer anything more than 4 minutes. After each OSCE, your question by answer books will be taken by the examiner and scanned to the national board for evaluation. And ward rounds for 10 minutes, it will be hardly 10 minutes for a candidate. And afternoon session, the clinical cases, we have 2 cases. One will be sent by the national board, which is a scenario common to all the centers, and the other will be the scheduled by the centers. So this is the lengthiest case in the next week's national board exams, and both these clinical cases has only 15 minutes discussions. So the examiners can ask or can concentrate only some areas of the cases, like either the pre-operative examination or investigation part, or the anesthetic management, or the post-operative, or so and so, like that. So that is it. And I would advise the candidates to always be at the station, at the center on the previous day itself, because most of the candidates are given centers within the state which are far away, because in Calicut students are given in Trivandrum, and Trivandrum students may be given in Ernakulam, like that. So, and in the current scenario, it will be better to reach the place on the prior day. And many centers, most of the hospital, we have only single entry. Many entries are restricted, so we will not have easy access. And you may have to show the COVID certificate. The securities may ask, why are you coming? You may have to undergo thermal scanning. So it will take some time, hurdles, to get into the exam center, and always have your COVID status certificate as per the government rules, if existing in that particular situation, to that particular candidate and even examiners. So better to be at the center well in advance by 7:30 or so that you can reach the exam center by the examination hall by 8 o'clock itself, so that you will get a clear picture of the instructions given by the center coordinator, because each centers will have their own form. Though the basic pattern is same, they will have designed their own methods of distributing the case there and so on. So it will be, and it will be explained before the OSCE session. That is the time given for briefing to the candidates. So, and you should not in a hurry to have these things. So be in time, well in advance, and be in good attire with white apron, with your register numbers well displayed, with your hall tickets, with your COVID certificates. And there is no need to carry your thesis or logbook to the exam, because those are not examined in these exams. So the mark distribution on the coming is OSCE, as I told, 25 OSCEs. We have only 4 minutes. And one thing to be remembered by the candidates is you will be provided only one paper, A4 size paper for one question OSCE. And you are supposed to write only on one side, which only one side will be scanned and sent to the national board. So whatever you write on second, you will not get a second page. Please don't write on the other side of the page, because you have 4 minutes, and be specific. Even you may be knowing to write an essay, but you are supposed to answer only to the points and on only one side, 4 minutes. And after 7 Viva stations, OSCE stations, you will have a rest time of 4 minutes. But during this rest time, you can only rest and relax, because your answer books will be taken by the examiners, and you cannot compensate your answer. Suppose you take only 2 minutes for one question, you cannot spare that extra time to next question. So each question's maximum is 4 minutes. So that has to be very careful, and only this has to be answer only on one side. And after that, you will be taken to the Viva stations as per the National Board guidelines in the corresponding centers, which is designed by the conveners. And they will give the instructions how the ward rounds. And the National Board has not given specific instructions how to do the ward rounds. Apart from that, you should have real patients. And it is 10 into 4, 40 marks. So it is the privilege or the coordinator of the centers to design how the ward rounds has to be conducted. And this sort of ward rounds has been going on in anesthesiology in Tamil Nadu, MGR Medical University, for so many years. They used to take to the ICUs and all. There were 6 cases ward rounds in Tamil Nadu. It is going on. So each center will decide. And clinical cases has been designed in the previous exams the same manner, one by the National Board and the other by centers. So the addition of ward rounds of 40 marks in the forenoon session is the new introduction of the National Board to include real patients. But the time constraint is so limited that you will have to see like a spotter and have to discuss maybe maximum of 10 minutes for those cases. And there is no separate pass in either OSCE or any station. You get aggregate of out of this 300 marks. If you get 150 marks, suppose one scores 150 out of 150 in the OSCE, even if you get 0 marks in the others, you will be passed. You will get a pass. So an average candidate can expect to get 100 marks in an OSCE. He needs score only 50 marks to get a pass in the other altogether Viva ward round. So be serious about the OSCEs. Come to the exam centers early, relax, so that if you come in a hurry and waste time and you are not adapted, you will lose one or first or second OSCE by some means you will be losing marks. So try to get maximum by OSCEs. So the OSCEs I told it is 4 minutes per station. There will be rest time for after 7 stations. The questions will be very specific and pinpointed, and answer only to the points. Write only on the single page on one side, which has to be scanned. And OSCEs are so designed that you can score full out of 6 out of 6 for one question, or if you lose the one question, you will lose to 0 marks also. So I'll just show 1 or 2 examples of OSCEs also. And these OSCEs are same throughout all the centers, because it is uniformly and simultaneously done by video conferencing platform by the National Board Command Center. Which these OSCEs will include entire spectrum of the training curriculum of the DNB anesthesiology to extract your core competencies, knowledge, clinical reasoning skills, and all those things. So this is one of a sample OSCEs. A question may be like this: an X-ray showing 3 questions, spot diagnosis, clinical features, management. You write these points, you get 6. You can score 6 out of 6, or if you make a diagnosis wrong, your sub questions will be wrong, and whatever you write the next questions will not carry any marks. So the first question is very important, and try to go through the subsequent questions, because subsequent questions may have some clue regarding the first question also. So all of you may be knowing this is a pneumothorax, but if you write pneumothorax, okay, you get a pass mark. If you write it as a right-sided pneumothorax, you get an extra credit mark. If you write it as a AP film with right-sided pneumothorax, having an endotracheal tube in situ, showing ECG lead wires, if you can write these 2 points, you may get additional points for the same thing. Suppose the candidates in seeing this X-ray thinks that the right-sided pneumothorax is the normal side of the X-ray, and he writes the other side, left side, as pneumonia or some consolidation or anything possible. A candidate can. So and in that case, you will lose the marks. Your clinical features will be wrong. Your management will be wrong. So be careful in diagnosing and answering the first question very specifically, especially in these sort of questions, because your subsequent questions may lose marks if you make a wrong diagnosis. So think twice before you answer. So this is another type of the question. This formula is shown, and the questions are: identify the drug and the importance of its chemical structure. What is the mechanism of action? 2 indications and 2 contraindications. You need write only these points. But if you don't identify the structure or the drug properly, you lose other things. And another thing, when setting the questions, 60% of the questions will be easy questions, will be answerable to an average candidates always. 20% questions may be a little tougher question for to know the competency or knowledge of a good candidate. And another 20 questions may be a very tough question also to know to give high extra marks, maybe 80% or above. So if you see such a tough questions, never get upset. The next question may be easier. You will be easier. So in this question, you can see this is the question has itself got some clue, because many of the candidates, I'm sure, will not be able to identify with this structure what is a drug. But you see when you ask the importance of this chemical structure in these drugs, you can imagine this is a mirror image of the two structures, same CH3, CH this thing, and two structures together. So a good candidate can imagine it may be a diacetylcholine. It is succinylcholine, maybe. And what is mechanism of action? So the structure has got the mechanism of action in its mechanism of action to have a depolarizing block. And in that case, 2 indications, 2 contraindications. So it will be easier. But sometimes never get upset by getting a tough question, because next question, because there will be 20% questions can be expected as tough questions, and 20% questions can be expected as very tough questions. Even if you lose 1 or 2 questions, you can easily score 100 marks in OSCE. So next is Viva stations. In that it is as done in the previous exams and all, 4 stations. The resuscitation, airway management. So, and resuscitation, don't think that it is only cardiopulmonary resuscitation. They may ask of airway resuscitation also, and airway management also. So airway equipments, airway management, like Hemlich maneuver or triple airway maneuver or cervical spine injury airway management. Such airway management also will come into this resuscitation. So these are the areas but you get only 5 to 10 minutes. So like this. And the next station is recent advances, research methodology and communication. So they may ask one question from recent advance, like a recent drug or a recent technique or a recent or something like that. And a research, for example, a COVID pandemic can be asked as a recent advance. Or a research methodology, they may ask 1 or 2 questions. And communication may be a communication skills. They may give a scenario. How do you communicate with the scenario, like that? The next station, the anesthesia equipments and drugs. Then investigation relevant to anesthesia is the 4th station. They will be asking about ECG, X-rays, ABG, and so on. So this will be immediately after the OSCE session for about 1 hour for the 10 to 12 candidates. And next is the ward rounds. So ward rounds, you will have real patients, and that also carries 40 marks, equal marks to that of Viva OSCE. So they may provide you with preoperative patients, like a preoperative thyroid patient, or a pregnant patient, or a child. Just see the spot or whatever, you have to carry out the instructions given by the center coordinate. Or they may take you to the ICU to give a post-operative case or a critical care case, or such cases which has been designed by but these ward rounds are meant to be done with real patients as per the instructions of the national board. So this takes out the problem of not having patients at all. So they have included patients, but with a limited exposure of the candidate to the patients. And afternoon session is clinical exam components. That is, there will be 2 clinical cases with 15 minutes per case, out of which 1 case will be decided by the NBE, which will be common to all the centers, and the examiners will ask questions for 15 minutes based on that scenario provided by the national board. And the second case will be a clinical skill case arranged by the center, which also carries 35 marks and 15 minutes discussion. And in those cases, there will be no real patients. There is no question of patients, but there may be a simulated case, or a mannequin, or a dummy, or a healthy volunteer will be given. Suppose the patient or a patient having some disease itself, evident, a thyroid swelling patient can be taken as a simulator case, or a patient having a previous spine surgery may be kept as a case for a taking the history and all. Depends upon the centers and the examiners, but there is no need for to examine the patient or to have close interaction with the patient, because it is not those are not real patients, and the aim is to have the clinical examiner skills and your knowledge assessed by the examiner. So this may be a healthy volunteer. You can see a simulated case. They may be telling, "I am coming here for an acute abdominal pain," something like that. You can take it as a healthy. Some healthy volunteers may be kept like a staff of the college or something like that. Or it may be a mannequin, a simulated mannequin. So if a mannequin is placed like this, you can see the spine board kept down, the collar, cervical collar is there, the head injury is seen here. So you can, the examiner will be asking head injury, trauma, spine board, cervical board. So this can be a clinical case scenario. So in this sort, the center can design whether it need to be volunteers, mannequins, or whatever, or simulated case, whatever it is, either single, double, or whatever it is, and it is left to the choice of the centers. So with this, I just wind up this talk, and this is not a scientific talk. I just try to give some clues to the exam-oriented exam students in this current scenario, and best of luck all to the exam-going candidates. And national bodies are having exams on the next week on 4th across the country. Around 480 candidates are appearing in around 40 odd centers. So I think this will help the candidates to have the exams appear with confidence. Thank you, Rajesh, and thank you, ISA, for giving me the chance to give the guidance to the candidates.
Thank you, Mubarak sir. It was very well, you have shown the candidates what they can expect from the new revised structure of the examination. And we are really thankful. ISA Kerala is very thankful to you for taking your time out and presenting this topic for the benefit of all our postgraduate students.
And if any students has any doubts or clarifications, with my level, I can just clarify to them regarding the exams and all.
So some questions are there in the chat box. Vijay sir, you can take it.
Yes.
Okay.
There is one question in the chat box, sir. What can be asked in ward rooms? Can you please give examples?
See, the national board has not given any directions apart from it is 10 into 4, 40 marks, and you should have real cases. Apart from this, there is no other direction from the national board. And national board the national board will be giving a training or a webinar for the center coordinates shortly before the examiners, and they will give any other direction if they will be giving. So in that case, the students, when go to the exam center at 8 o'clock, the coordinators in the centers, they will disclose to them if there any specific direction from the national board, or how they have designed in the national in that particular center. In my mind, what it came was, because to have a limited exposure, a few preoperative patients can be kept. For example, a patient with a visible thyroid swelling, or a pregnant patient, or just a pediatric child who is to be operated as a pre-op, like a spotter, they can be kept 1 or 2 cases, or they can be given a post-operative case, a patient on 3rd post-operative day after laparotomy on epidural infusion or something like that, or a patient, or some ICU cases, a patient with a polytrauma on mechanical ventilator, or a patient with a chest tube drain, or a patient having multiple or some ICU scenarios or post-operative cases, or a patient having in the post-operative having a stridor after thyroidectomy, or with a scenario, thyroidectomy patient, they can keep a scenario page. This patient had a thyroidectomy, a post-operative thyroidectomy. So that is left to the center coordinator to decide what is as of now, unless there is a specific instruction of the national board. So this is the thing I can give at this point. Okay. And it may differ from center to centers as of now, unless there is specific instructions. Okay.
So that is left to the center to decide what to keep.
Yeah. As of now, unless other directions comes.
Yeah, thank you, sir.
There is a new thing added in the national board. In Tamil Nadu, there is water rounds for so many years. There they used to give ICU cases, something like these scenarios, and we used to do it in 5 to 10 minutes at bedside. Here, that all those things, and whether it is bedside or whether to give patient spotter or on the examiner site or whatever, maybe that all is left to the discretion of the center and their coordinator.
There will be 4 cases like that into 10 marks each.
No, they have not decided. They have not specified that 4 cases. They have told 40 marks. That's all. So, and the time is very limited because in hardly 1 to 1.5 hours for 10 candidates, it will be you get hardly 10 minutes. So, if you get four cases means you can, and that has to be finished before lunch because at 2 o'clock we have to start the next session, afternoon session. So, they have given only maximum 1.5 hours for these 10 questions. So they mean to have a very minimal, like a spotter, a 5 to 10 minutes discussion. So that will be decided by the centers.
Okay, thank you, sir.
Okay.
There are no more questions in the chat box, I think.
Candidates, if they participants, if they want, they can unmute and they can ask the questions. They can allow them to unmute themselves if they want. We have seniors also there as participants.
And slowly we are changing to the patient's back. So the scenario may change back to the previous in the next time maybe.
Sir, I appreciate the presence of Vishwanath Hiramat, sir.
Yeah, very good presentation, sir. It will be helpful for the candidates.
Thank you, sir. Thank you very much.
Thank you, sir.
So, if there is no more questions, shall we conclude the sessions, sir? Moderators, Vijay sir and Rajesh sir?
Yes. Yeah, we'll wind up.
Yeah, we'll wind up the session. Over to Nasser sir for his concluding remarks.
Yeah, all the talk by our eminent speakers were excellent. Especially Mubarak sir talk was really a very useful information the postgraduates who are going for exams next week, because they have an idea how they have to face the exam and what are the possible way the questions come. Very useful talk, sir. I take this opportunity to thank all our speakers, all our senior members, all our officials and students and practitioners who have joined us this evening. Thank you all. Good night. We'll wind up.
Thank you.
Thank you.
Thank you, sir. Thank you very much. And our next session will be on next Saturday at 6 p.m.
Good night.